Good morning. Welcome to day 2 of the American Society of Allergy Professionals Conference. Had some awesome speakers yesterday, and we've got some awesome ones again today. My name is Donnie Stone. I have a clinic in Rockwall, which is just a little east of Dallas, for those of you not familiar with here. Just a couple of quick announcements. One, just remember to, when we have our break this morning, go over to the exhibits and see those booths and get your little bingo cards filled out so we can get those turned in. Turn those in here at the front where the registration desk is, and we have 5 $100 Amazon gift cards that we will be drawing for if you have all of these signed. And there is, isn't it a one freebie there, Katie, that we didn't have? Okay. Good. And then we've had some people ask about being able to download these presentations, and we are trying to get that worked out so that we can do that. When we get that figured out, we'll get that information out to you. So let's go ahead and get started. This morning, our first speaker is Dr. Savannah Sommerhalder, back there in the back. She's been with Aspire, joined Aspire in allergy and sinus after successfully completing her fellowship program in allergy and immunology through the University of Texas Medical Branch in Galveston, Texas. Dr. Sommerhalder received her medical degree through Ross University School of Medicine and completed her pediatric residency training at the University of Texas Medical Branch. She served as chief fellow during her fellowship and then was assistant chief during her residency. She is currently a member of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, the American Academy of Pediatrics, and the Texas Pediatric Association. She needs more to do with her free time. She is board certified through the American Board of Allergy and Immunology, as well as the American Board of Pediatrics. Dr. Sommerhalder offers comprehensive care for both children and adults in the areas of food and environmental allergies, as well as sinus services. And she has certification through the American Board of Allergy and Immunology and the American Board of Pediatrics. So let's welcome Dr. Sommerhalder to the...
All right, can everybody hear me okay? Beautiful. So my name is Savannah Sommerhalder. I'm an allergist, and I'm going to talk to you guys today about food allergies. I ended fellowship 4 years ago, so I've been practicing in private practice for about 4 years. I didn't know how passionate I was about food allergies until I started seeing the patients. Can I just get a little kind of guesstimate around the room, like how many of you guys take care of patients with food allergies? Can you just raise your hand? Okay, so a lot of people in here, not everybody. If you have, you know that patients with food allergies are really special. So that's why I've become so passionate about them. The kids are super resilient, super strong. I know we have some food allergy parents out here too, as well. Who are also equally as strong and resilient as the kids. There's not a lot of compassion for these families in the real world, and so I think it's part of our job to provide that compassion for them, that care, that education, especially as specialists. I think they should come into our office, maybe not knowing what allergies they have, and they should be able to leave with a lot of answers, because that's our job. And so that's what I hope you guys can leave this talk with today. There we go. Okay, I have no relevant disclosures. So some objectives for my talk today. I'm going to talk just a little bit about the pathogenesis of food allergies, introduce it a bit, try to squeeze a lot into it today, so bear with me. The epidemiology, natural history of food allergies, decision-making tree. So when are we supposed to test these kids or adults that come in and see us? When should we not be testing them? I want us to be able to identify IgE-mediated food allergies versus non-IgE-mediated food allergies or sensitivities. And then also, I want us to be able to interpret test results and determine when to challenge, which can be very challenging. Okay, so just a couple of cases to get our brains working this morning. So this first case, it's a 6-year-old female. Her chief complaint, she came in with hives, vomiting, lip swelling, something that sounds like anaphylaxis, right? She also has a pretty significant history of severe atopic dermatitis. Just to summarize this briefly, she's at 18 months of life, she had her first ingestion of liquid cow's milk, which resulted in diffuse body hives, vomiting, anaphylaxis. Her parents took her to the ER. She did receive epinephrine, steroids, antihistamines, and albuterol nebs. Discharge did okay. Since this time, she's been very picky. She only eats chicken nuggets, French fries, and cherry tomatoes, which you guys will see these patients. Oops, excuse me. See if I can go back. She's never ingested any tree nuts. She's definitely never eaten like scrambled eggs or hard-boiled eggs, but her mom thinks that probably she's ingested baked egg, but she's not totally sure. So she was seen by an outside allergist who performed initial testing, and then they came to you in clinic. These are the tests that she brought. We're going to come back to this in a little bit, but I just want y'all's brains to kind of get going on her history. These are her labs. What am I going to do? Am I going to test this patient? Am I not going to test her? Am I going to tell her to avoid all of these foods, or are we going to slowly start introducing them? You decide to do a skin prick percutaneous food test on her, and these are her results. So we tested her for cow's milk, egg, peanuts, and then we threw the tree nuts in too because mom said she'd never had them before. All right, so here's another patient, a 3-year-old male. This guy has no history of food allergies. However, he has a sibling with a really severe peanut allergy. So his parents have been very scared for his whole 3 years of life to give him any peanuts at all or any tree nuts. And so they just come in wanting testing before they introduce those things. He does have atopic dermatitis, but it's mild. These are the tests that you do. So you start with skin prick testing on the right. You get a peanut of 34. You also tested tree nuts because the parents asked you to, and everything was negative there. And then as you can see on the left, we got a couple of specific antibodies to look at as well. All right, and here's the third case. This is an 18-year-old guy. He doesn't have any complaints really. He just wants to join the military, and they saw something in his chart that he had a peanut allergy, which he doesn't really remember all the details about, and he just wants to get it off of his chart. He does report a pretty regular diet, although generally he avoids egg if it's not cooked into something. When you ask him a little bit further, he says, yeah, it bothers me a little bit when I eat it, so I avoid it. Peanut makes his mouth a little bit itchy, and he does have a history of anaphylaxis at 12 years of life with ingestion of peanut. But currently when he eats it, just a little itchy, he says. And he brings his test with him, and this is what he brings. And so for him, he's got a lot more than just one thing, right? So more than just peanut. He was told that he was allergic to all these things, and he's in trouble. So we do skin prick testing on him, and we see kind of similar results. Like you got a lot of different things that are positive. All right, so as a specialist seeing these patients, something that we should take pride in is opening up these patients' diets as much as we can. They've got a lot of restrictions, even if they just have one known food allergy. But if they come in with tests like the previous patient, that's a lot of restrictions that maybe they were told, you have an allergy to strawberries, sweet potatoes, beef, chicken, all these things. And it's pretty unlikely that that's the case, but you need to clear that up for them to open up, to really change their quality of life and open up that diet. Okay, so when should a patient be tested at all? Which diagnostic tests should be used? And what is the utility of the tests to predict future reactions if we're able to do that at all? So these things should be going through your mind when you see these patients. Food allergy patients come in at many different ages for many different complaints. Some of these complaints are immune mediated and some of them are not. Joint pains, abdominal pain, maybe a little bit of diarrhea here and there. You'll see that and you'll hear that, but you'll also see hives, angioedema, coughing, wheezing following ingestion of these foods. And so that's what we're going to focus on today. So this IgE mediated food group. Quick definitions for us. So for a food allergy, it's an abnormal immune response, which is reproducible with exposure to a specific food. We heard a little bit yesterday about the importance of a sentence. If you need to hear it once, maybe it's not worth hearing again, but if you need to read it more than once, you should read it more than once, something along those lines. So this first one, a food allergy is reproducible. If a patient had a reaction, but they've eaten the food since that time, that's not reproducible. Therefore, that person probably does not have that allergy anymore. So it's really important to remember that one. An abnormal immune response, which is reproducible with exposure to a specific food. There must be an initial sensitizing event that primes the immune system for subsequent responses. And then in that right column there, food sensitivity, is the presence of IgE antibodies to a food, frequently in the absence of clinical reactivity. So if they test positive on their skin, they are sensitive. They are sensitized to that food. However, are they clinically reactive? That's our job to find out. Food allergy epidemiology. Food allergy affects 3 to 5% of adults and up to 8% of US children, depending on the study that you look at, under 5 years of age. So 90% of food allergies are caused by very specific foods. 2 to 5% of food proteins encompass most food allergies. A lot of patients will come in asking you to test for a lot of different foods, but we have to remember that there's only a few foods that are actually going to cause most allergic reactions. Food allergies have generally increased over the last 10 years. The hypothesis for this, which people will ask you, we've got a couple, we don't know for sure. So there's a hygiene hypothesis, a vitamin D hypothesis, a delayed food introduction, which we suspect this is largely one of the causes, and why we now recommend introducing allergenic foods earlier. But for every patient, we're not going to have a good explanation for why they have it. We just know that maybe they do, and we're going to help them with it. Briefly more on prevalence. I'm going to skip past this just for the sake of time. All right, how does food cause an allergic reaction? It's very complex, actually. It's not just eating the food and you've got the reaction, and that's as simple as that. It's very complicated. So to put it simply, though, this is a pretty good graphic. The patient will ingest the food. That food protein is absorbed. The food allergen gets taken up by some antigen-presenting cells, and then it gets taken up by a T cell, and you've got two routes that it can take, a non-IgE-mediated route or an IgE-mediated route. In the IgE-mediated route, your body has created antibodies against this food, and that's the problem. That's what's going to create all the big cascade of allergic reaction, put simply. All right, who are good candidates for testing? Do they have a history of an IgE-mediated reaction? Yes or no? We have to know the difference between those two. Are they having hives, angioedema, cough, vomiting, pretty immediately following the food ingestion, or are they having 24 hours of belly pain afterwards? It's really important to understand the difference in that. Does the patient have moderate to severe atopic dermatitis? These patients require testing as well before introduction of certain foods if they have not had them already. And do they have a sibling with IgE-mediated reactions to foods? This is kind of a soft call depending on the family and what they've eaten so far, but something that's important because there can be a correlation with siblings with food allergies and their younger siblings having it as well. So the first thing we'll get when we see the patient, if they haven't brought in labs, is a good food history. What's a suspected food trigger? Symptoms with exposure. How close was it to them eating the food? Was it 6 hours later they had vomiting, or was it 30 minutes later? Was the patient further evaluated, and how were they treated? Is it exercise induced? Were they exercising right afterwards? Have there been further ingestions and they ate it okay, or it's happening every time? It's reproducible. If it's egg or milk, can the patient tolerate baked products? Does processing the food change the allergenicity for this patient? When was the last exposure? Is it a 15-year-old and the last time they ate it, they were 2? Are there other avoidances? Have they ever used epinephrine, and do they have epinephrine? A bit more on history. Do they have a history of atopic disorders, atopic dermatitis, asthma, eosinophilic esophagitis? That one's very important, and so is atopic dermatitis. And I didn't make a slide on this, but there's a lot of patients that say, my baby has atopic dermatitis, and when they eat wheat, their skin flares up. I need them tested to know if that's their allergy. We've been avoiding it, and they do better. The recommendation for those patients, actually, even if they tested slightly positive, they had no further reactions than atopic dermatitis flare, is to continue feeding the child that food, because we don't want to help them create a true IgE-mediated food allergy. So I didn't put a slide in there about that, but that's something really important to remember as well. Physical exam is very important to see how the kid is doing. Atopic dermatitis, again, is one of the big things that we look for. Do they have dermatographism is also very important when you're doing testing. Are they going to test positive for everything you test them for just because their skin is sensitive? And then, a full respiratory exam is important as well. Okay. Which foods are we testing? So we've got a patient who sounds like they have an IgE-mediated reaction. Which ones are we going to test them for? Is the reaction to that specific food, or is it to an unknown food? Is it an allergenic food? Does this antigen exist commercially? So are we able to test them for it, or do we need to have the patient bring the food in so that we can test them for it? Here's some of the top 9 allergens: peanuts, sesame, shellfish, tree fish, milk, soy, egg, and wheat down there at the bottom. Again, about 2 to 5% of food proteins collectively are the ones that are allergenic that we watch for. There's two different important types of of allergens: class 1 allergens, class 2 allergens. On the top there are more traditional allergens that we look for. These are heat resistant. They are acid stable. So when you're digesting, they're going to be stable when they're moving through your stomach acid. Stable to proteases in water, soluble. They're abundant in food, and their epitopes are linear. And then class 2 allergens, plant-derived maybe, they're heat labile. They change shape when they're heated. They're more associated with pollen food allergy, and these epitopes are conformational. So epitopes, we're allergic to proteins, right? So epitopes are parts of the allergen that are allergenic, that antibodies attach to. So they're really important, and the shape of them is important because that determines if they're going to be denatured when they're heated or not. So really quickly, just some more basic stuff. On the left, you've got linear. On the right, you've got conformational epitopes. Again, linear is heat stable. So you can see that small red part that's actually attached to the antibody. When it gets denatured or heated or digested, that little red part remains. And so the antibodies that are circulating are still going to be able to find it, attach to it, and elicit a reaction. When it's conformational, it's heat labile. When it gets denatured or digested, that red part disappears in this graphic. Therefore, the antibodies are not going to be able to see it anymore, and the reaction is a lot less likely to happen. So foods that we're thinking about in addition to like oral allergy syndrome type foods are baked egg and baked milk. One more basic science graphic. Cross-reactivity, does it matter? Of course it matters. So we know that it matters with oral allergy syndrome, but it also matters with foods. Patients come in with cashew sensitivity. We test them and their pistachio comes out positive, but their cashew is negative. What in the world? They've never had pistachios, but we know they've reacted to cashew. So it's very important. And this graphic explains why cross-reactivity happens. As I mentioned in a previous slide, you have to have an introduction of the food to elicit a response at like a primary ingestion. So here's on the left, you've got your primary allergen, and you can see the blue square, that red triangle, the red circle, and the green circle. My eye vision's not very good over there. But you have your primary ingestion. Essentially, you're eliciting a response down towards the bottom. And then when you move to the right, you're ingesting a different allergen that does share 2 of those similar epitopes. Not all 4, but 2 of them. And when you ingest it, even if it's for the first time, those antibodies are able to recognize just those 2 and elicit a similar response. Okay. Here's a couple of cross-reactivities that we frequently see in food allergies. Pecan, walnut, cashew, pistachio. I usually tell patients these are like sisters. If you've got one, you've got both of them, typically. Okay, lab evaluation. I wanted to touch on this because this is really important for us. We don't want to test too broadly. When we have patients that come in and they want a lot of testing, we have to really be judicious about which tests we choose for the patient, for their benefit. This is a really good sheet to screenshot or to come back to because it actually tells us the protein that we're looking for to test. And then in the left column, it tells you the food. The next one, it is your protein. On the very far right, it gives you a little bit of notes about it. Is this one heat stable? Is this one heat labile? If the patient's ovomucoid for egg comes back positive, is that a good thing or a bad thing? Can we challenge them to baked egg? Should we stay away from egg altogether? And so this is a really important slide here. I'm not going to walk through every single one of them, but it's an important one when we start evaluating them. Pollen food allergy syndrome. This one we see all the time as allergists. They present with a little bit of itching in their mouth. They don't like how it feels. Maybe it goes into their throat, but it's usually all year round. Maybe it's worse during the fall, a certain season. This is really important to talk to them about. Hey, it may not be a food allergy. It may be an actual sensitivity to a pollen, and there's a cross-reactivity because of those epitopes. Now you guys know. Similar with latex. So with latex, we know there's a 35% risk of patients with latex allergy also reacting to these foods over there on the right. More commonly would be like banana, avocado, kiwi, chestnut is one of those 2. But sometimes we'll see fig, pepper, tomato, potatoes, which is not a very allergenic food. So something to keep in mind. And then the reverse is also true. If the patient comes in with a reaction to one of the foods, there's an 11% risk. We'll also have a risk of reaction to latex. food allergy evaluation. So a little bit more, as y'all practice, you will see some weird tests that patients bring in. Frequently, we'll see IgG tests. So they'll come in with like, I don't want to use specific brand names, but they'll come in with tests that are IgG tests. So be conscientious of what kind of test it is. If you see IgG and not IgE, it's not our kind of test. It's not a test that's going to predict well what the patient may react to. So keep an eye on that. These are like very weird ones. I've only seen a couple of these. Iridology, so they actually evaluate the iris. There's some tests that use like electrophysiology to try to predict inflammation in the body. So these are not tests that we ever want to run as specialists. Okay. And we can gently maybe let the patient know that these are not great, and I'll let you be the one to determine how gently you do that. For food allergy testing, we've got skin prick testing, we've got specific IgE testing, which is where we're testing for those antibodies against a specific food protein. But the gold standard is an oral food challenge. Actual gold standard is a double-blind, placebo-controlled oral food challenge, which I do not do in my practice. I don't know that there's many that do anymore. Unblinded challenges seem to do just as well. Skin prick testing and specific IgE is there. A couple of quick pearls. Positive percutaneous or skin prick testing to foods and elevated serum IgE can indicate the presence of specific IgE antibodies, which is sensitization, but not necessarily clinical reactivity. Increasing wheal and diameter of the skin prick size and increased level of serum IgE can be associated with a higher likelihood of a clinical allergy, but it does not determine the severity of the reaction. How allergic is my kid? Are they going to have anaphylaxis? The answer is not clear. We can't tell them that just based on their tests. Okay. Sometimes they'll on test results there will be a level of severity, a 2, a 3, a 4, and patients will tell you, "Oh, my doctor told us we're a 2, so we're very allergic." Take that with a grain of salt, okay, because it's difficult to predict. Skin prick and IgE values are not comparable between different foods. Fresh fruit testing is required frequently for pollen allergy syndrome, and we never use IDTs for foods. There are a couple different studies on when should we challenge patients based on their labs, or how allergic are they based on their percutaneous testing. It's not totally consistent. Okay, so I put 1 or 2 in here just for us to have on here as a guide, but it's not a hard and fast rule, and it's not always going to be correct. Okay. Taking on the left-hand side, just to pull this apart a little bit, you're likely reactive if your number is greater than, in the top, you've got milk, egg, soy, wheat, peanut, tree nuts, and fish. So likely reactive if it's greater than, for milk, for example, a specific IgE of 15, likely to react. For egg, if it's over 7, likely to react. Soy, and on down the page. The next row down is possibly reactive, and then unlikely reactive. As you can see from these, it's not surely reactive. It's not hard and fast. It is likely, maybe, possibly, but they're good numbers to kind of guide you as you go. This is very similar. I just wanted to point out that age does make a difference. So for egg and milk specifically, for kids that are under 2 years of age, that's different than kids that may be older than 2 years of age. So the positive predictive value for egg, for specific IgE levels of 2 is about 95%, which is pretty good. I included this slide in here just to point out that when we look at labs, they're different. Not all foods are the same. So I don't know if y'all can read this here, but on the left-hand side, that blue circle around it is cashew, and then lower down is almond. And then to the right, the 2 columns that I circled is positive predictive value and negative predictive value. Those numbers are incredibly different. So for cashew, if the patient has a skin prick size of 3, the wheal is 3. I can't read that number. Can someone read that for me? The positive predictive value number for cashew if the wheal is 0.82. And then can you read the same thing for almond? Okay, so those are hugely different numbers. Okay, so the positive predictive value is the likelihood that patient is going to have a clinical reaction with that size. For almond and cashew, those are very different. So if a patient comes in with a cashew concern, their number is 3 versus an almond that's 3, I see those numbers very differently. Okay. This is a little thing of phenotypes and endotypes of food allergies. These are very important because people present very differently. Their allergies come from different places. But I just want to point out, again, the differences, the lack of, I guess, continuity, if you will, of skin prick testing and specific IgE testing. Even for classic persistent IgE-mediated allergies, which is that very top row, it's not extremely reliable. The size of skin prick testing can go from a little bit big to very big for patients who are actually allergic. And then same thing with the specific IgE. Their numbers can go from two pluses, so a little bit big, to very big again. So it's just not extremely reliable. You have to use clinical history. Okay, to challenge or not to challenge? I don't know how I am on time. Okay, a few more minutes. Okay, great. Oral food challenges. Again, this is the gold standard for allergy testing. But who are you going to challenge? Who do you feel comfortable challenging? This is definitely going to be a joint decision, but it's very important to know and understand what the patient's body is going to do when you put the food in their mouth. Because again, the skin testing and the specific IgE testing is very helpful, but it is not a 100% yes or no answer. So if the patient has a serum IgE and or skin prick testing that are not consistent with their history, they may be a good person to challenge. When the patient and you agree that the risk from history and the test results are outweighed by the benefit and possibility of adding food into the diet, opening up their diet as much as we can, which is a big goal. Determining whether food allergens associated with chronic conditions like atopic dermatitis or EOE will cause immediate reactions. Is it just worsening their skin? Maybe we'll keep it in their diet. Is it causing an IgE-mediated reaction? We need to know because they've been avoiding it for 3 years because they didn't want to worsen their eczema, and now they maybe have developed one. So they may be a good candidates. Somebody with a lot of restrictions, they only eat chicken nuggets. Maybe we need to introduce a couple more foods there. Assessing the status of tolerance to cross-reactive foods, and assessing the effect of food processing, if it's baked, lightly cooked, things like that. This chart here is a really, really good one to have on hand if you are doing food challenges. It gives you the food. It breaks it down by type of food, the age of the patient, and what a full serving size is. Because with food challenges, that's what we're doing. We're not only putting a little bit in their mouth, we're giving them a full serving size, and we want to see if they can tolerate that. If they can tolerate a little bit, that's cool, but we don't want them to be afraid at all. So we want to give them a lot. There are a couple different protocols for oral food challenges, depending on the patient, really, and your comfort level. Y'all should decide how many steps you want to take. The Practal protocol down at the bottom, this one's very long. You're putting in the patient's body about 5 grams of protein, ultimately 5, 6, somewhere around there, and that's a lot. So if the patient's 2 years old, that may be too much for them. If it's an adult, that's a great dose. If it's something like garlic, maybe you don't want to go all the way up. It's not a ton of protein in garlic. So for that one, maybe you just want to get a clove and cut it into pieces and do 4 steps. And so there's 4-dose protocols, there's 6-dose protocols, there's 7-dose protocols. So depending on the patient, depending on your comfort level, there's a lot of options that that should be safe for the patient, as long as y'all decide together on that. Natural history of food allergies. Just really briefly, there is a likelihood that a lot of these patients will outgrow the foods. So when do you challenge based on their age? That's something to consider as well when you're thinking about challenging. For cow's milk, about 50% will outgrow it by 5 years, and that number goes up and up and up as they age. There's some studies too that show cow's milk will be outgrown by the age of about 75% by the age of 3. So it really depends what study you look at. But bottom line for that one is we know that there is a high likelihood that the patient will outgrow cow's milk. Not 100%, but it's definitely possible for them. Very similar numbers with egg. Wheat is one too that frequently will be outgrown. When I was preparing this talk, there was actually a study that said even if the IgE number is over 100, if the patient doesn't have a history of an IgE-mediated reaction, it's worth challenging those patients because they will likely outgrow it as well. Here's a little visual of that just for peanut, milk, and egg. Peanut, about 20% of kids will outgrow peanut by the age of 6. For tree nuts, that number is about 10%. And egg and milk, you can see, is about 80% by 6 in this study that was done. Oh, and I just felt like I needed to throw this in as well. For patients with severe eczema or egg allergies or both, these patients should be, by guidelines, they should be brought in to see you to have testing done, skin prick testing done, or specific IgE testing prior to introduction of peanut. We extrapolate that out to egg and potentially some other foods as well, but for sure for peanut. And then depending on the size of the reaction, you either can have them introduce it at home, introduce it in the office, or stay away from it completely, depending on the answers. And this gives you very specific guidelines on that. And that's it. Those are my kids, and that's my baby who's now 4 months, who we gave her peanut last week. So, any questions? I kind of sped through a lot of information, so if anyone has any questions, let me know.
What about patients who have a very high IgE level and you're trying to interpret the unit of capsid might be 4 or 5 kg per liter and they have 1,000?
Yeah. Yeah, so that's a really good question. I'm actually going to go back to one of our patients here who had a very elevated IgE. You have to take that into consideration. I'm glad you brought it up. So when the total IgE is elevated, a lot of times that will happen with patients with atopic dermatitis. It can skew the rest of the results. And so I don't know of a specific calculation you can do to even it out. I don't think that one exists. Just something to be taken into account. This guy, for example, let's go see if I can go to his. This guy, so his IgE, it wasn't hugely high, but it was, 1100. His milk was over 100, and all of his other numbers were elevated too. For a patient like this, if they had never ingested a food like any tree nuts, for example, and they all were coming back 20, 25 on their specific IgEs, I would probably talk about challenging those with him. It depends on your comfort, though, because there's not a firm answer. You else have any questions? Uh-huh. Okay. Mm-hmm. Yeah. So in an ideal perfect world, you would convince them that they actually don't need testing. If they don't have if they don't have a history. It's hard. Uh-huh. Yeah, then I agree. I would probably do labs first, and then they can bring it in with you, and that way you don't have to, carry the conversation on longer than it needs to. Uh-huh. What other questions? Yeah. It's really hard, and it depends on the patient because they have providers, an acupuncturist, chiropractor, whatever, that they really trust and gave them these results. I always validate them personally. I don't validate the results. I validate their feelings. I tell them what I know. Here's what I know based on statistics. I share that with them. And then I ask them, what about this food? Like, do you think we can introduce that? You want to try it in the office? Would that make you feel more comfortable? A lot of them say yes. And then we kind of build rapport and go from there. Sometimes I will tell them if they are very persistent about it. This is not sponsored by anything or has no data behind it. Sometimes I'll tell them, okay, like cow's milk is a really good one. Stay away from it for 6 weeks. See how you feel. I usually choose cow's milk and wheat. Stay away from it for 6 weeks and see how you feel. If you feel better, great. Take it out of your diet, no problem. If you cheat here and there, it's not going to be life-threatening. But we want their quality of life to be good, and if that would make them feel more assured, that's usually how I word it. Here we go. Right. Yeah, one of those tests I put on there, like, I don't, maybe some of y'all have seen this. Yeah, and so it's difficult, but if they trust it, they trust it, and so.
So, this is for testing. Prick is high, labs are low, or vice versa.
Mm-hmm.
You have a test that you rely on for the other.
So, did I rely on more than the other? History is the best thing that I look at. It depends. I think it depends. I pay a little bit more attention to the specific IgE just by habit. However, their total IgE may be elevated, and then you can't trust it. And so it really depends on the patient. I thought you were going to ask me about some tests that have come out more recently than these things that I didn't add in here. Basophil activation testing. There's like a bead-based assay that's available now. That's also available. These are still typically what is done and what we brought to you, so I didn't touch on those, but those are something that you may hear about. Anybody else? That's it. Okay. Really good.
All right, awesome. We're off to a good start. Our next speaker, Dr. Stacy Silvers, many of you are familiar with, is a board-certified allergist, specializing in food allergy diagnosis, treatment, and prevention of both children and adults. Dr. Silvers oversees the allergy program and protocols and also leads the food allergy and oral immunotherapy program at Aspire Allergy and Sinus. Dr. Silvers is considered an expert in the field of food allergy diagnosis and treatment. Most of his patients' parents think he's God or a close thing thereof. Dr. Silvers earned his undergraduate degree from Southwestern University in Georgetown and went on to receive his doctorate of medicine at the University of Texas Southwestern Medical Center in Dallas. Dr. Silvers completed his pediatric residency at St. Vincent Catholic Medical Center in New York, New York. He also did an allergy and clinical immunology fellowship at the Cleveland Clinic. Before joining Aspire Allergy and Sinus team, Dr. Silvers spent 6 years in private practice, actively involved in food oral immunotherapy, and was named director of the Dallas Food Allergy Center. He is also a member of the American Board of Pediatrics and the American Board of Allergy and Immunology. In 2019, Dr. Silvers was named the best allergist in the Statesman Best of the Best contest. He has certifications with the American Board of Allergy and Immunology and the American Board of Pediatrics, and he is going to be talking to us about non-IgE mediated food allergies.
Thanks, Donnie. So, when we talk about food allergies, we are, you all right? Okay, all right. The first things we think about are IgE-mediated food allergies, right? We just had a great talk about this. This probably constitutes a lot of what we see in our clinics, but we have to remember there are a whole host of non-IgE-mediated food allergies out there. We have to keep that in mind when we're seeing patients. For the three we're talking about today, FPIES, allergic procticulitis, and celiac disease, 2 of those are almost exclusively in infants. So if you're not seeing kids, as we said yesterday, take a nap if you want. And then the celiac disease, we'll touch on a little bit, but usually isn't something that's a big part of our practice as allergy professionals. Okay, I have no disclosures that are relevant for today's talk. FPIES, food protein-induced enterocolitis syndrome. This has been something that we've been aware of since the 1970s. However, we didn't really have a diagnostic code for this until 2015. So in a sense, this is kind of a relatively new disorder, meaning I don't have a lot of data to talk about with this, all right? Also because it's pretty uncommon. The incidence in the US, usually we say around 0.28%, although it's really poorly defined. Poorly defined in many ways because there's no diagnostic test for this outside of food challenge. Talk about that in a little bit. But one thing to keep in mind with these patients, they're pretty atopic. Even though this is an IgE mediated, this is a food allergy. So we see upwards of 57% of these patients have atopic dermatitis when they come in our door. So we'll be seeing these in addition to routine kids who are coming in. I should say, the vast majority of these are going to be pediatric patients. I have seen some adults who have this disorder, I think, right? So keep that in mind, and we'll talk about this different foods that we see in different age groups as well. FPIES is divided up into kind of two types of reactions, and the one we think of most commonly is acute FPIES. This is where kids will eat the triggering food intermittently. It's not something they take every single day. And classically, they'll have vomiting 4 hours afterwards. And this isn't just spitting up, this is vomiting, repetitive vomiting. These kids are throwing everything up and then they keep going, all right? A sizable percentage will also have diarrhea that tends to occur after that. And really bad cases, we're gonna see lethargy, pallor, and the big thing to keep in mind with FPIES is you can actually go into shock, hypovolemic shock, because they're throwing up so much. But in between these episodes, when they're not eating the food, perfectly normal kids, growing, healthy, happy. So it's just these acute episodes of vomiting, delayed vomiting with the triggering food. What's even more difficult to diagnose, though, is when it's chronic FPIES. This is very difficult. Again, this is almost always in infants, usually in kids who are formula fed. With milk being a common trigger, they're taking milk every single day. They're going to have these symptoms on a daily basis. They will have intermittent vomiting, not quite like they do with the acute episodes. They'll have chronic diarrhea in addition to that, and these kids are sick, right? Because they're eating the triggering food regularly. So we're going to see failure to thrive, poor weight gain. They don't look good. Good news is you take the triggering food out of their diet, they feel better in a week or less. So pretty easy to fix as long as you're thinking about it and you do something about it. Interesting note though, once you take it out of the diet and they try it again, they try it too soon, then they can present with an acute FPIES reaction. They'll have that vomiting 2 to 4 hours later. We do now, since 2017, I think, have kind of a diagnostic approach to these patients that with acute FPIES. What you'll see on here, there's no lab tests, there's no skin test. This is all historical. So you have to take really good detailed notes on these patients to start thinking about these conditions. As we've said already, vomiting 1 hour to 4 hours later. It's going to be hard to make a diagnosis after one reaction, right? What routinely happens is kids eat the triggering food for the first time. 2 hours later, they vomit, they vomit, they vomit, they go to the ER. Oh, they've got a GI bug, right? You don't really start thinking about this condition until the second episode. And that's why it's on a minor criteria here. Having one food trigger kind of puts you at risk for other food triggers. So if there's 2 things we're dealing with, we really have to keep this in mind. We'll talk about that more in a bit. And then I said lethargy, pallor, going to the ER, getting IV fluids, diarrhea, hypotension, hypothermia. So these are all things you have to keep in mind for kids who present. Chronic is even more ill-defined. Basically, if they don't look good and they have intermittent vomiting and diarrhea and failure to thrive in a young formula-fed infant, think chronic FPIES. To make things even more confusing, we have people who have atypical FPIES. Like I said at the very beginning, FPIES is not IgE mediated, but we do see some kids have serum IgE or a positive skin prick test to the triggering food. Suggests maybe there is a little bit of a role for IgE, maybe not in all kids. Again, we don't really know what's going on in some of this, but we see it in up to 1/4 of patients with FPIES. The kids who have a positive prick or a positive IgE to the offending food tend to have a longer course. So there is kind of some prognostic information we get from testing these kids. But it's not a routine test that we do for this, okay? I will say though that if you do allergy testing and they're sensitized to their non-FPIES trigger, it doesn't seem to have much impact on the FPIES. That's just kind of a separate entity. Deal with that as you would for a normal kid with a positive test. Not well understood. All we know is you eat the food, you get gut inflammation, and then you get hypovolemia. The T cells and the inflammatory cytokines are not well defined. Probably is some interleukin-8 tryptase that's been found in some studies, suggesting neutrophil and mast cell involvement, but we don't know all the details. Because there's no test, what we really have to do is rely on retrospective studies. This is data from Dr. Spergel that gives us an idea of what are the common foods. And far and away, the most common one is milk. Almost 70% of FPIES kids have milk as a trigger, followed by soy, grains, egg, meat, fish. So of the grains, I want to highlight a couple of rice and oat. They tend to be the more common ones. For any of those who have kids, what are common infant cereals when we first start introducing solids? Rice cereal, oatmeal, things like that. So this is something you will certainly see if you do this long enough. For the meat, fish, peanuts, and tree nuts, I want to highlight a couple here, chicken and turkey. Poultry is kind of a common trigger. So in many cases, when we're looking at giving guidance to families, we recommend holding off on poultry until they're a bit older. Next, we have vegetables. Again, I want to highlight sweet potato, maybe pea. Again, a common food that we give to young kids at a young age to start solids. So we tend to see that. And fruits, banana, again, we give that to babies all the time, right? So that's kind of the common theme with this. You see it a lot. The majority of kids with FPIES have only one food trigger, 70% or so. So that's good, that's great. It's the least amount of impact on the quality of life, but we do see kids with more than that. 20 to 30% will have 2 to 3 foods, and 10% will have more than 4 food triggers. So if you found one, great, maybe that's all you have to deal with, but keep in mind that other foods could be causing this as well. Management, well, it's easy for us as providers. We just avoid the food. Difficult for our families. We all know that because we deal with food allergy patients all the time. Specifically for cow's milk triggers, if you're going to have to kind of give some guidance on what do I do now? I can't give my kid infant formula. If breastfeeding is an option, awesome. But in many cases, it's not an option, so we have to find an alternative. In most cases, using extensively hydrolyzed formula is going to be sufficient. But not in all cases. 10, 20% of them, we're going to have to even go further and use an amino acid-based formula. Sometimes we can consider soy formula as well, remembering that soy is a common trigger for FPIES as well. So if you're going to do that, I would start kind of a low dose and kind of creep up to make sure they can tolerate that as well. It's gotten very popular, at least in my clinic, to try to use other types of milk. Goat, sheep, not a good alternative, particularly in a condition like this, because there is a lot of extensive cross-reactivity. The allergenicity is pretty much the same. Not going to be a good option. Baked milk, I get this question a lot. All right, so I can't give my kid formula, but as they get older, can I give them muffins and cakes and things like that? Maybe. I've certainly got a lot of kids in my clinic who are able to do that. I didn't tell them to do it. They just go out and try it. It's their first birthday, and grandparents give them a slice of cake. There is some data, I think, out of Australia that suggests that a lot of kids can tolerate baked milk in this condition, but it's not something we routinely recommend. Yes. Okay. So if you have cow's milk trigger for your FIs, you're a little bit more likely to have a solid food trigger as well. So when they do start introducing solid foods, keep that in mind, make sure they're aware. Sometimes we need to recommend doing these introductions in the clinic. Maternal avoidance of the FPIES trigger is generally not required. So that's a big question I get as well, particularly if they're going to be breastfeeding. In the vast majority of cases, they don't have to worry about that. They can go ahead and have a normal diet. We do want to try to get these kids to introduce as many of these foods in their diet as possible. And I kind of do it in a normal way. Do a new food every few days, start small, introduce to higher and higher doses, because at the same time, we're trying to minimize the risk of IgE-mediated food allergies. Other things I do for our patients, I usually give them the prescription for an anti-nausea medication, just to keep on hand. If we can keep these kids from vomiting, they're going to do better overall. Try to keep them out of the ER as much as possible. But along those lines, most ED physicians or providers don't know what this is. They're going to diagnose as a VGE. I usually give them a letter, pre-printed form that says, hey, this kid's got FIs. We need to think about this in the differential. Here's how you treat it. IV fluids, steroids. So it's something that they have on hand in case they do end up in the ER. With introduction of different foods, I've pulled this from the consensus guidelines, and I usually just give it to our patients. And I say, start on the left with these lower risk foods, and then move to the right. That's usually how I go about introducing new foods. Quite safe, and parents like having a guide on what to do next. Because these parents are very anxious about trying new foods. It's kind of dramatic to see your kid throw up for hours, so giving them some information, very, very helpful. Natural resolution. Numbers are all over the place, just like it is with any of these types of studies. In the US, 35% will resolve by age 2, 70% by age 3, 85% by age 5. Numbers are different in Australia and South Korea, though. So it's really tricky when we don't have a test to tell us when this goes away. Solid food-induced FIs in general take longer to resolve, so keep that in mind when you're thinking about doing food challenges. But here's a nice study looking at kind of average resolution times for FPIES. Me personally, I usually wait at least 2 years after the last known reaction. It's a little conservative, but none of us like doing FPIES challenges because I haven't placed an IV in probably 20 years. So I don't want to have to learn how to do that on the fly. Okay. So moving on to allergic proctocolitis, oftentimes referred to as cow's milk allergy, cow's milk protein allergy. It's another non-IgE mediated allergy, obviously. It seems common in infants, but in actuality, it's really not, maybe 0.16% of healthy children. And like with FPIES, milk's the common trigger, but we need to keep in mind that other foods can potentially cause this as well. And it's the kids who classically have the bloody stools, right? Almost exclusively in infants again. It can affect both breastfed and formula-fed kids. And unlike with FPIES, sometimes these proteins are passing in breast milk. So in a lot of cases, the mothers are going to have to take out the food trigger in order for symptoms to resolve. Yeah. Blood-streaked stools, currant jelly stools, which I don't know, no one knows what currant jelly is. I Googled a slide to put up here, but Google calls it listed as a sensitive image and it shades it out. So I decided not to put it on here, but you will know it when you see it for sure. Some may have some irritability, but generally these kids are pretty happy and healthy. There's no failure to thrive. They're gaining weight appropriately. There's no vomiting, no severe diarrhea. They just have weird looking mucousy poops. Again, non-IgE mediated, we know even less about the pathophysiology of this compared to IgE mediated allergy. But essentially you get edema and erosion in the distal colon. It's another allergic condition where it's all based on clinical history. You do have to keep in mind that there are other things to think about. A lot of you adult allergists probably haven't had to deal with intussusception and neck in a long time. Keep it in mind. Hopefully that's not walking through your door. And generally, like with FPIES, you take the offending food out of the diet, they're going to feel better within a few days, generally within 2 to 3. It may take up to a week or 2 though. So before you start going crazy and taking more foods out of mom's diet or changing diet even further, I would give it a full 2 weeks to know. Serum IgE testing is not helpful. Patch testing is all over the place. That probably doesn't help all that much. The one thing that may help to some degree is the fecal occult blood tests. Can help with the diagnosis if there's blood in the stools. You know it because of this. May help with resolution. But in general, we don't send any of these tests at all. If there's more than one food trigger, again, quite uncommon. Think about referring to a dietitian. The vast majority are going to have these outgrow by 12 to 36 months. I certainly see kids where it resolves by 9 months. And usually you can just tell them to introduce this at home. Start with 1 ounce, move up to 2 ounces, 3, 4, 6 ounces over the course of a week or 2. Occasionally, these patients will come back in for prick testing, IgE testing, just to make sure they haven't developed an IgE-mediated allergy. We're telling them to avoid a common food allergen. Not a bad idea to make sure they haven't developed a different type of allergy over that year or so. And once it goes away, it's gone. It doesn't really come back. Monitoring for growth and nutrition, but generally, like I said, these kids are doing well as long as you get them on an appropriate alternative to the milk. Celiac disease, this is what I wanted to put on there. But we're going to see these people come in. They want to know if they're allergic to wheat and gluten and on and on and on. So we have to have a little bit of an idea of how to go about diagnosing this. So quickly, I'm not an expert by any means on celiac disease. Autoimmune disorder triggered by the ingestion of gluten. Gluten's found in wheat, barley, and rye. We get villus atrophy, intraepithelial lymphocytes, crypthyroplasia. More common in women than men. Worldwide prevalence of 1%, and it's one of the most common causes of malabsorption. Okay, so what's going on? And I'm really only going over this to give you a little background on why we test for celiac disease the way we do. Gluten's a storage protein that's incompletely digested, so these large peptides are left behind. So these peptides are then taken up by these allergy-presenting cells, these specific APCs that present it to T cells, which in turn releases all sorts of mediators such as interferon gamma. B cells start producing specific antibodies. We get lymphocyte infiltration and then tissue injury. And for most of us, we know how this presents: diarrhea, bloating, gas, abdominal pain, weight loss, fatigue. In children, we have to be aware of it with decreased growth, delayed puberty. Keep that in mind. We can also see anemia, joint pain, and skin rash. So just quickly, we only see this in 10 to 15% of those with celiac disease, but because all these weird rashes come to us as allergy professionals, keep it in mind. Dermatitis herpetiformis, as the name suggests, looks a little bit like herpes. So vesicular papular rash, oftentimes sporadic. People are scratching at it, so there's excoriations. And in severe cases, there can be lichenification as well. Classically on the elbows, knees, buttocks, back, and scalp. So what can we do when these people come in our doors? We're certainly not going to go do a scope, which is required for a definitive diagnosis, but we can send testing. And testing is really actually quite good. So the tissue transglutaminase, IgA and IgG, have a really high sensitivity and specificity for this. So that's generally the first line test. You can order that, that's easy to do. If we need to, we can send the anti-endomysial IgA antibodies, kind of the second line test. Specificity is great, almost 100%. Sensitivity is not as good, so that's kind of why it's second line. And then less commonly ordered is the deaminated gliadin peptide IgE and IgG. These can be used in people with IgA deficiency. So in case you don't know, sizable percentage of people out there just don't make IgA, 2 to 3%. So when you're ordering these labs, remember to add on a total IgA. Because if the IgA is low, then you can't really interpret the tests and you have to revert to the IgG tests. And then those patients are going to get referred to us anyway because their IgA is low. Important point, these people have to be on a gluten-containing diet. So if they come in and they haven't eaten wheat in 6 years, there's not much we can do besides go eat some bread for a few months, and then we can decide to test you if you want to do that. There is genetic testing. Now that's something we could do while they're on a gluten-free diet. Almost 100% of patients exhibit the specific genetic profile. So a negative test is pretty helpful. A positive test is less helpful though. Certainly it's not going to make it a diagnosis for you. And it really is just avoidance. That's the mainstay of therapy. And as long as you do that, these patients generally do quite well. There are a few rare non-responders, but that definitely is not my problem. Malnutrition, osteoporosis, intestinal lymphoma, infertility have been associated with celiac disease. And there are other autoimmune conditions to keep in mind as well. And that's all I've got. Questions? Okay, great. So I usually will give, there's a 4 milligram ODT tablet that I prescribe, and usually I'm having the infants break it off and get half of it. Works quite well. That same consensus guidelines has a great handout on at-home management. I'm usually giving that to the patients as well. So vomiting doesn't last very long. They're still pretty happy and healthy. They're still wanting to try to eat and drink a little bit. We can manage this at home. But it's when they really start becoming lethargic and they're not responding very well, they probably need to go in and get IV fluids. Usually single dose is sufficient because it only lasts for a couple hours anyway. I don't think I've had a patient where I've needed to give more than a single dose. Okay, great. Thanks, y'all.
Thank you, Stacy. All right, moving right along, our next speaker, Ms. Katie Larson. She graduated top of her class from Baylor College of Medicine with a Master of Science in Physician Assistant Studies. Katie also holds a master's degree in teaching and was an elementary school teacher before becoming a PA. She has a personal connection with allergic conditions and treatments, as one of her sons successfully underwent treatment for his food allergy several years ago. Katie loves being able to offer patients treatment for their allergic conditions because, thanks to her son's experience, she knows how life-changing it can be to no longer suffer from allergies. And in her spare time, she loves traveling with her husband and her 2 boys. And she's also the president of the society here and did a ton of work putting this conference together. So give her your appreciation. And she's going to talk to us about food allergy treatment.
How about now? Yay! Now figure out how to stick this back on. Okay, guys. Today we are going to play a game. I know y'all are so excited. This is the elementary school teacher in me coming out. So sorry, not sorry, actually. We are going to play Jeopardy about food treatment. Just by like a show of hands, how many of you guys participate in some form of food treatment, whether that's omalizumab, food slit, or OIT? Okay, we got a lot of y'all, and it's pretty even on each side of the room. So I'm actually gonna split you. I'm cutting you, Barty, in half. You can choose which side you want to go on. I'm gonna split you guys to the sides of the room, and we're gonna see which side of the room is more food allergy ninjas. So it'll either be you guys or over here, you guys, and. Y'all cannot just rely on Silvers over there. That is not okay. And so I don't have buzzers or anything, and I don't have super cool music like Dr. Anand did with Jeopardy. So she's clearly the goat about this. But we'll go ahead and let one side kind of choose a question, and then we'll give you guys the opportunity to answer. And if you don't know the answer, then we'll switch it to the other side. I want scorekeepers though, because this is very important. You're going to win bragging rights, and that's it. But who wants to keep score on this side? Okay, there we go. He's getting out of having to answer questions. That's what's happening. Okay, so here's my little thing, let's go. This is not my son. He kind of came up when they talked about son. That's my one of my OIT patients, actually. He's a cutie. Disclosures. I was on an advisory board about this time last year for Genentech, and they do manufacture and market omalizumab. If anybody wants to extend that disclosures list, I am always happy to get more disclosures. But I always put these two guys on as disclosures as well. These are the guys who have biased me sort of towards food allergy treatment. One of them just talked to us, that's Dr. Silvers, and the other is my son. Dr. Silvers treated my son for egg, peanut, and hazelnut allergies about 9 years ago. This is them last year at this meeting, actually, together. My son's 20 and is a sophomore at A&M now. So that's why I decided to become a PA, because it was just so life-changing for us. So let's get started on Jeopardy. Okay, we're gonna let this side choose first. So somebody yell out. We've got 4 different categories. We've got omalizumab. That's the new kid on the block as far as food treatment is concerned. That's that anti-IgE subcutaneous injection that you may have used for years and years now for other indications like asthma, chronic hives, and nasal polyps. It's now approved for food allergy. We've also got food slit as a category, sublingual immunotherapy, those little drops we put under the tongue of the food extract. And then we've got 2 categories for OIT, or oral immunotherapy. That's that treatment where over the course of many months, we feed the patient the allergen, starting in very small amounts and increasing to a full serving of the food. So there's OIT reactions and OIT potpourri. So somebody on this side, choose something. I love it. Okay. Can you hit food slit 300 for us? Okay. Food slit doses are, yeah, that was actually 200, but that's okay. Here we go. Caleb is a 6-year-old who has completed a year of maintenance for peanut slit. His serum IgE and skin prick wheals have declined nicely since beginning slit. The family would like to know if Caleb could tolerate candy that's cross-contaminated with peanut. You schedule Caleb for this type of appointment to find out. What do you guys think on this side? Oh, Dr. Christians for the win. That's my supervising physician, y'all. What is a modified food challenge? You're exactly right. Okay. So the first thing we know is how well does slit work. When we're giving these doses of the allergen under the tongue, it is a very, very small amount of protein. For peanut, equivalent to like 1/100th-ish of a peanut every day. So how do we know that these patients are protected from accidental ingestion or eating foods that are cross-contaminated? First of all, we've seen studies, right? And several studies have pointed out that after a year, 2, 3 years on these food drops, these patients are able to eat 2, 4 peanuts. Now, of course, that's not as dramatic as something that we see with like OIT where they eat the food, but it could be enough to help protect them from cross-contamination or accidental ingestion. How do we know that? So there was a study done in Jackie in 2018, which we'll actually talk about a little bit more when we talk about omalizumab as well. But it actually kind of gauged a risk of reaction for eating these highly cross-contaminated foods. And it found that ice cream is actually the highest risk food. But if you have a reaction threshold of 300 milligrams, which is about a peanut-ish, that your reaction, risk of reaction to reacting to something like ice cream is 0.3%. So very, very low. So if we can get them to a level where they can tolerate about a peanut, then their risk of reacting to cross-contamination food is very low. The only way we know that, though, is if we bring the patient in the office and put the food in their mouth and see if they react to it. So we do something called a modified food challenge. This is a typical protocol that we use at our practice for a full food challenge when we're trying to decide, like Dr. Summerhalder told us about today, whether they're actually allergic or not. The full food challenge goes all the way to 4,000 milligrams, right? These kids are not going to be able to tolerate that amount. So we modify the food challenge. Basically, we just chop off the last 2 doses of the food challenge. We do a 5-dose food challenge up to 300 milligrams of protein. And if a patient can tolerate that much peanut, then we feel pretty comfortable telling them that they're okay to eat these foods that may be cross-contaminated with peanut. And that really does open up these kids' diets a lot. Okay. Can you go back to click on those 3 little things and go back to the board? Okay, this side, what do y'all want? Make a choice. Silvers is like somebody else talk. Omalizumab 200. This one dovetails nicely with what we just talked about. Okay. Omalizumab is approved to reduce the risk of severe reactions to food and may allow patients to consume these foods safely. What do you guys think? Yes, excellent. What is cross-contaminated products? I would have also accepted accidental ingestion of food. Okay, so omalizumab was approved, I think, like late February for the treatment of food allergy after a study called the OUtMATCH study, which is technically still ongoing. There are 3 stages of it. And the first stage involved giving kids omalizumab, actually adults as well, omalizumab for 16 to 20 weeks. So they did a food challenge before. They either gave them omalizumab or placebo for about 16 to 20 weeks, and then they did a food challenge afterwards to see what their threshold was. Everyone in the study was allergic to peanut and to other foods. So the first kids or patients allergic to peanuts, 67% of them in that active group that received the omalizumab could tolerate 600 milligrams of peanut protein. That's like 2-ish peanuts, whereas only 7% who were in the placebo group could tolerate it. And then, of course, the other foods, they actually used a higher protein amount for the other foods of 1,000 milligrams. And it depended on the food, but somewhere between 41 and 75% of the patients in the study could tolerate 1,000 milligrams of their other allergens. How do we know that's important? It's that study that we just referenced in Jackie. I stole this from a talk at the college last year. Somebody did a really nice job on that slide. Where they basically took different threshold amounts for patients with peanut allergy and found that if your threshold was only 3 milligrams, so you would start reacting if you consume 3 milligrams of peanut protein, you had a very high risk of reaction to cross-contaminated items. Somewhere between 30 and 50-ish% of the time, you may react to a cross-contaminated item. But if you can reduce that or increase the threshold to about 300 milligrams, that's about 1 peanut, then your risk of reacting to those items reduces by over 99%. So 600, 1,000 milligrams is definitely enough protection to where these patients may be able to consume foods that are cross-contaminated. It's important to know that omalizumab is approved for food avoidance. So these patients are not going to be able to eat a full serving of this food in general. They should still be avoiding the food, but if they have an accidental ingestion Or if they relax their diet a little bit, they may be able to eat some cross-contaminated items. Okay, go back to those 3 things. This side, what do y'all want? Y'all are going for the big guns here. Okay, OIT potpourri for 300. I keep meaning to cross them off so we know what we've done. This is my kid. I didn't change his name because, you know, he's been advertised way too much about food stuff. So Brendan, he's actually 20 now, but we'll go with it. 18-year-old male who completed egg OIT 8 years ago. He's currently dosing 18 milliliters of liquid egg white 3 days a week. He's going to college next year, and his mom would like to know if he can go even longer between doses. You consider scheduling Brendan for this specific type of food challenge a month from now. Dr. Christians, good job. What is a sustained unresponsiveness challenge? That's exactly right. So when we feed these kids their allergens and we get them up to eating, you know, close to a full serving of this food in some cases, what do we do from there? Do they need to keep dosing every single day long term? We found over the years that we can kind of reduce dosing days, but how long they can go between doses is variable among different patients. I found this graph, which was in an article that's published this year, actually, and I thought it was very helpful. It shows different studies for milk, egg, and peanut OIT. If you look at the vertical axis there, that is showing how long they were on therapy. And then the horizontal axis shows how long they stopped therapy before they tried to eat the food again. And that's what sustained unresponsiveness is. You stop eating the food for a while, and then you come back in the clinic to see if you can still tolerate it. If you look at the red line that goes horizontally across there, there were 2 peanut studies that did peanut OIT for about 2 years, 100 weeks, and then they stopped dosing for varying amounts of time. One thing that wasn't listed on here was the sustained unresponsiveness rate. So the nerd that I am, we looked them up, and you can see there that if they only stopped dosing for about 12 weeks, about 35% of patients in that study were able to tolerate the challenge when they came back in. But as you avoid for longer and longer, those numbers go down, where if you were to avoid your dose for a full year, only 13% of patients could come back in and tolerate their dose again. So what we know from that is that increasing tolerance, waning tolerance with longer dose avoidance. The same thing interesting with milk is if you look at the vertical line on milk there, that's silver. That was a study where they only stopped dosing for 2 weeks, but they did it after 1 year in therapy. They stopped for 2 weeks to see if they could do it. Then they did 2 years in therapy, 3, and then 4 years in therapy. And what you notice with those rates is after stopping milk for 2 weeks after only 1 year in therapy, 21% were able to continue their dose. But if they had been in therapy for 4 years, that 200 weeks there, 70% of them were fine for stopping for 2 weeks. So with that, we know that there are increasing sustained unresponsiveness rates the longer you're in therapy. Other things we know about who might be able to pass a sustained unresponsiveness challenge is that if your testing at baseline before you started OIT was lower, you're more likely to pass one of these sustained unresponsiveness challenges. So we sort of put that together in our practice, and these are the general guidelines we use. They're not hard and fast by any means, as most things with food allergy treatment are not. But in general, to be eligible for a sustained unresponsiveness trial where we have patients stop dosing for 4 to 6 weeks and then come back in for a food challenge, we want them in OIT maintenance for at least a year if they're preschoolers or 2 years if they're older kids, no reactions in the past year, and we'd like to see like a 75%-ish reduction in either their skin prick test will or their serum IgE. I know Dr. Silvers does a lot fewer of these days. He just kind of reduces dosing days as kids go. I do think, though, the scenario in this vignette is a good time to think about this kind of challenge. As the mom of an OITer who is currently in college, these kids do not always dose like you want them to dose. And so it's just comforting to know that a patient may be able to go 4 to 6 weeks and still resume their dose. Okay, let's go back to the board. You guys, what do y'all want? The only one we haven't done for 300 is OIT reactions, if you want the big money. Okay, let's do OIT reactions for 300. Okay. Ellie, a 14-year-old milk OIT patient, dosed at midnight because she'd been out late that evening. She had cramps from her period earlier in the evening and took some acetaminophen around 10 p.m. You receive a message from her at 1 a.m. that she's having a reaction to her dose. These two cofactors may have played a role in her reaction. Exactly. Nice work, guys. What is menstruation and lack of sleep? Okay. So we know that there are specific cofactors that can lead to reactions during OIT. Menstruation is one of them, and as is lack of sleep. In our practice, we don't have any specific guidelines for dosing while a patient is on their period. We just kind of check to see. It doesn't happen to everyone that they do have reactions. So if we see a pattern, then we'll start to make changes with them. With my patients, I tell them no good dosing happens after 9 p.m. for the lack of sleep thing, because then there's a spruce message at midnight, right? So I ask my patients to try not to dose after 9 p.m. There's other things there. There was sort of a red herring in that question stem. She took some acetaminophen. If I had written that she took ibuprofen, that could have been another cofactor, because NSAIDs sometimes can also precipitate reactions during oral immunotherapy. Okay, back to the board. Okay, we're out of 300 questions. What do you guys want? Okay, omalizumab, 200. Oh, I think that's, oh, maybe we did. It's 300's available. Okay, Barty, make it work with the things. Okay. Omalizumab is currently being studied in conjunction with this food treatment modality. You're offering for the wrong team. Silvers, get your people in order. But is she correct? Yes, she is. So, give them some points too, Bertie. It's being studied in conjunction with OIT. So we talked about that Outmatch study. It had a couple of stages. Stage 1 was just omalizumab alone. And that is what led to the FDA approval of omalizumab for the treatment of food allergy. Currently ongoing is this stage 2 of the trial. And in stage 2 of the trial, they actually gave them omalizumab for 8 weeks, and then they started OIT. They continued omalizumab for another 8 weeks while doing oral immunotherapy, and then they actually pulled the omalizumab and continued OIT for another 44 weeks before food challenging these patients without omalizumab. The results for this, we were talking to somebody like yesterday who thinks maybe like 2026. So it's going to be a little while. We're hopeful, though, that it may lead to a approval for omalizumab to be used in conjunction with OIT. Can you try it right now in practice? Payers are being a little weird about covering omalizumab. It is only technically approved for avoidance of food allergy right now. But if you were theoretically to start it before, I don't know what's going on with that noise. If you were to theoretically start it before you started OIT, there's usually a 6-month approval there before your prior authorization needs to be renewed. And that's all I'm going to say about that. Let's go back to the board. Sterling, what do you want? 100. Okay, let's do it. Oh, okay, I like it. Omalizumab dosing for food allergy is based on these two patient parameters. Total IgE and what else? Weight. Exactly, guys. Okay, so technically approved for weights between 10 and 150 kilograms. Total serum IgEs between 30 and 1,850. I just got a 1,878 approved last week. I was a little proud of myself. So you just, payers are being really finicky, unfortunately. Sometimes they will approve it outside of the dosing table and sometimes they won't. I would just let patients know that there's a possibility there may be a denial if they're not inside the dosing table. Other things to know, minimum age is 1 year. The dose is given every 2 to 4 weeks subcutaneously, and the maximum dose is 600 milligrams Q2 weeks. That's 4 times the dose we usually give people with chronic hives, right? So it's not an insignificant amount of omalizumab some of these patients are getting. Okay, go ahead. Okay, guys, what do you guys want over here? We've still got 100 and 200 available for food slit, OIT reactions, and OIT potpourri. Make a choice. OIT reactions for 200. Let's do it. Jackson is a 13-year-old with a severe oak pollen allergy who is also in OIT for cashew. Jackson is most likely to experience a significant reaction to his dose during this month. That's a really good question. I will accept a couple of months. So it's okay if you don't have the exact month that I say here. Okay, good job. What is April? Okay, so we have noticed this anecdotally. We literally had one this weekend. We were just talking about this morning. This is probably an issue with ragweed and a dose. So every fall, every spring, there tend to be more reactions to OIT doses. Somebody did do a study on this, and these kiddos that have allergic rhinitis are much more likely to react to their doses during these high pollen seasons. Really important to get environmental allergies under control before starting OIT. So consider putting these kids on SCIT or SLIT for their environmental allergens. We don't like to build up in OIT the same time we're building up in SCIT. So getting them to maintenance for SCIT. SLIT's pretty safe. It's okay to build up while you're building up OIT as well. Okay. This side, what do you guys want? We've got food slit for 100, 200, OIT reactions for 100, OIT potpourri for 100 and 200. Okay, OIT potpourri for 200. Walker, it's funny because I changed kids' names. That's not his name, but he is one of my patients. He's a 14-year-old who completed walnut OIT 2 weeks ago. You schedule him for a food challenge to this nut due to its high cross-reactivity with walnut. If you were paying attention to Dr. Summerhalder's talk, you know this answer. What is pecan? You guys got it. So what's the deal with walnut and pecan and cashew and pistachio, right? There was a study a while ago. I always appreciate a study with a good name. It was called the Nutcracker Study, where they were kind of trying to determine this cross-reactivity. They found that about 2/3 of people with a walnut allergy were also allergic to pecan, but every single person in the trial or in the study that was allergic to pecan was also allergic to walnut. So if you're allergic to walnut, we're going to treat walnut. If you're allergic to pecan, guess what? You're also allergic to walnut, and we're going to treat walnut. So the answer to somebody who comes to you and says they have a pecan allergy and they want to do pecan OIT is great. Let's do walnut OIT. We're going to do walnut OIT and then bring them in for an oral food challenge to pecan after the walnut OIT. We have a really good pass rate with that, like higher than 95%, I think. Same thing is true with cashew and pistachio. The one we treat is cashew, and then we bring them back in for the food challenge to pistachio. Can you go back to the board? Okay, we've got food slit, OIT reactions, and OIT potpourri for 100, and also food slit for 200 left. What do you guys want? Food slit for 200. Let's do it. Food slit doses are very small and comparable to a dose we would see on this day of OIT treatment. What do you guys think? I heard somebody, first day, good job. What is the first day of OIT? So I just pulled our particular OIT day 1 sheet here. We go to 6 milligrams of protein for OIT day 1. Slit maintenance doses usually range from around 1 to 7 milligrams of protein. Our particular slit doses for our practice are around 2 milligrams of protein a day. So that's about right in the middle of an OIT day 1. And then once again, for perspective, we've talked about this, but a single peanut kernel weighs about 1 gram, contains 250 to 300 milligrams of protein. So they're literally getting less than 1/100th of a peanut per day, which is why slit is such a safe treatment. Okay, back to the board. Okay, we only have 100s left for the last 3. What do y'all want? Okay, OIT potpourri for 100. Mia, 5-year-old OIT patient who skipped dosing yesterday due to illness. Mia's feeling better now, and mom contacts you to ask how to restart the dose safely. You tell mom to start Mia back at this fraction of a dose. What are you guys gonna say? She only missed 1 day. Okay, what is a half? Now, all of this is kind of subjective, right? And I'm not even aware of any published studies of exactly how to resume doses, but these are questions we are asked clinically all the time. So I feel like we should just give you guys the answers of what to tell patients. So in general, if they miss 1 day, you can resume at a half dose and then the full the next day. If they're missing 2 to 3 days, then it's better to go up by quarters. If they miss 4 to 7 days, we usually add in 1/10 of a dose there at the beginning and then go up by quarters. If they miss 7 or more days, that is time to tell them, I'm sorry, you need to come into the clinic to restart your dose. And they come in the clinic, they restart it under supervision, usually at 1/10 of a dose, and then depending on how long they've been off, do that 2 to 3 days for each of these increasing amounts until they're back to their full dose. Now, there's caveats to all of this, right? If somebody has been in maintenance for a really long time and they're only dosing 1 or 2 days a week, then why are we having them restart at 1/10 of a dose when they skipped, 4 days? Doesn't make sense. But also if somebody's really reactive, they've got a history of anaphylaxis, they've got a history of EOE or ELORs, then we're going to restart them at maybe slower than these protocols. Okay, back to the board. I think we only have OIT reactions for 100. No, we've got food slit for 100 and OIT reactions for 100. What do you guys want? Food slit for 100. This adverse event is the most common symptom we see with food slit. It's you guys, right? Most common symptom. You guys got it. What is oral itch? And these numbers actually are all over the place for different food slit studies, ranging from 4% all the way to 37% of doses cause oral itch. The bottom line is let patients know you're probably going to experience some oral itch and it's not a concerning adverse event that we are worried about. If you make it a big deal, it will be a big deal, right? The other thing to know is that if you exclude oral itch, even in that study where 37% of doses experienced oral itch, by excluding oral itch, 95% of doses had no symptoms with slit, and there was only 1 epinephrine-treated reaction in that particular study. We used to have a 0% epinephrine rate at our practice for slit. I think we now have had 1 patient need epinephrine. It's a very safe treatment compared to something like OIT, where about 10% of patients need epinephrine. Okay, the last one is OIT reactions for 100. So that's what we're going to do for you guys. Brooke is an 8-year-old in Cashew OIT who has been experiencing nausea, intermittent nausea and vomiting between 3 and 23 hours after a daily OIT dose. You become concerned that Brooke has developed this condition. Oh, somebody even got the fancy name of it. Nailed it. Okay, so EOE, eosinophilic esophagitis, or ELORS, is eosinophilic esophagitis like OIT related syndrome. That's just a fancy way of saying we're not going to put a scope down this child's throat to figure out if they actually have EOE, but they sort of are looking like this is happening to them. So what % of patients in OIT develop actual biopsy-proven EOE? Some of the studies, it's like a less than 3%. In clinical practice, we very rarely scope these kids. We found that if you take the dose away, the symptoms go away, and so there's really no need to do a scope. In clinical practice, though, somewhere around 8 to 11% of kids do experience these symptoms of nausea and vomiting hours and hours after a dose, so long after the dose that the parents think that it is not related. So always good to keep tabs on, and also a rise in their serum peripheral eosinophils above their baseline. Make sure you have a baseline on these kids before you start OIT. That's why we always say to order a CBC with DIF when you're ordering your serum IgEs for patients, so that you will know if they have risen significantly. The question is it a deal breaker? Do you need to stop if they have these symptoms? And the answer to that is usually not. Between 50 and 75% of kids in these studies are able to continue on with OIT. We're going to down dose to a level that's sort of tolerated with no symptoms, hang out there for about 8 weeks, recheck the peripheral serum eosinophils. If they've sort of dropped back closer to baseline, then they can slowly up dose as tolerated. Okay, that's it, guys. Can you go to the last slide, that little arrow at the bottom? So thank you, guys. I'm probably out of time. If you have questions, you can always email me. That arrow at the bottom on the left. Oh, who won, Barty? Oh, good job, guys.
Do you have the soundtrack to We Are the Champions over there? You could play that real quick for us. All right, our last lecture before we take our break is on EOE, and I won't go through Dr. Silver's fine credentials again, but do let me remind you, as soon as we're here, we'll be on break till 10:45. Please go and visit the booth. It's not possible to do this conference without our sponsors, and so let them know how much you appreciate it, and listen to what they have to say. And as soon as he's finished, and we'll take a break and be back at 10:45.
There we go. All right, so asked to talk about another non-IgE mediated allergy, EOE, and what we can do as allergy professionals to help manage these patients. Again, I have no disclosures for this talk. We'll go through the history and epidemiology, pathophysiology, presentation, diagnosis, current and future treatment options, and then kind of wrap up with what we can do specifically as those of us in allergy clinics. So kind of like I mentioned with FPIES, EOE is kind of new. Like we first started noticing it as a distinct clinical entity in the 90s, but we really didn't get any guidelines on diagnosis and management until 2007. The most recent update to those came out in 2017. And since then, there's been some changes, not a lot. We'll talk about some treatment options that have come out in the last few years. But again, there's a lot more we need to know about EOE to really get even better management than we have now. Prevalence is around 55 out of 100,000, and that was in 2006. It's probably increasing. Some of that's because of better awareness. We're doing more scopes and biopsies on these patients, but it probably doesn't explain it all. There probably is an increasing incidence in EOE in general. More common in males, in a 3-to-1 ratio, and there tends to be kind of a biphasic, bimodal presentation for this in kids, kind of 6 to 10 years of age, and adults 30 to 40. So that's kind of when we see people coming in the door for us. So again, I'm not going to go through all the details of this. You've seen a slide similar to this in multiple talks this weekend, right? There's barrier dysfunction, allergens presented through specific APCs, goes to the T cells, and the T cells do badness because they release all these bad interleukins that promote allergic responses. And all of that allergic response leads to tissue remodeling, just like with asthma, like we talked about earlier, and that's what causes symptoms. How do these patients present? It's a little bit different between kids and adults. Usually because adults have been dealing with this for a much longer period of time before they come in. Adults will oftentimes have the classic dysphagia. Food is stuck, it won't go down. They end up in the ER with a scope to take it out, and hopefully you get a biopsy at the same time, and that's kind of where we get the diagnosis for a lot of adults. But in addition to that, they'll have heartburn, chest pain, maybe some GERD-like symptoms. Children, they're not going to come in and say they have a hard time swallowing for multiple reasons, but one, because they haven't had the illness for long enough. They're going to have more vomiting, regurgitation, abdominal pain, and maybe feeding refusal. They feel bad when they eat, I'm not going to eat. So you have to have a pretty high index of suspicion for the kids, and we'll talk about some factors to think about to raise your awareness when you see these kids. Just a note about the dysphagia. Obviously, patients aren't going to use that word. What you'll see, though, is let's say food gets stuck. They start taking a long time to eat because they're chewing and chewing and chewing, trying to get that piece of steak, as small as they possibly can. Maybe they're putting ketchup on their steak. Sounds gross, but they need something to help it slide down. So they're changing the behaviors in order to manage the condition. So how do we diagnose this? We need our GI colleagues to do this for us, because really what we need to see is an EGD with biopsies, and you're going to see 15 eosinophils or more per high-powered field. We generally like to see at least 6 biopsies because this can be patchy infiltration in the esophagus. So in order to make sure we're seeing what we want to see, maybe take multiple biopsies. In addition, they have to have the clinical symptoms that go along with this, and we need to exclude other possible causes of eosinophilic inflammation in the esophagus. What do we see on those biopsy results? We see superficial laying of eosinophils, microabscess formation, epithelial hyperplasia, and some signs of eosinophilic degranulation as well. Not things that we need to worry about, but you'll see it on the pathology reports. What do we need to make sure we're not dealing with? Eosinophils can be found in the vast majority of the GI tract, but not in the esophagus. If they're in the esophagus, something's wrong. These are conditions that are associated with eosinophilic inflammation, although oftentimes it is going to end up being EOE. And this is what our GI docs are going to see. The majority of people are going to have linear furrows, so these long lines that are kind of going up and down throughout the esophagus. Mucosal rings are pretty obvious when you see them as well. Small caliber, so that's why you have the dysphagia. There's just not much space for these foods to go down. We get the white plaques and exudates in some patients, and in really bad cases, you're going to get strictures where you can't even put the scope down. Food's getting stuck. Those are the people who are having impaction. In children, we can see some of these, but up to 1/3 of kids are going to have a normal appearing esophagus on visual scan. So we have to do biopsies on these kids. But we are going to see some of the linear furrows, esophageal rings, and white plaques in a percentage of those kids as well. When we start talking about treatment options, how do we know things are improving? One of the ways is symptoms, right? Our patient's just feeling better overall. But GI docs may use things like the EREF score, basically ways to say, oh, visually this seems to be getting better. There is less edema, rings are going away, exudates resolving, furrows are decreasing, and the stricture has gone away. All right. So when you see these patients long-term, hopefully we're going to see the grades start going towards 0, meaning normal esophagus on exam. So what do we do for these patients? How do we treat them? Well, there's a few different ways we can go about it, and there's no real consensus to say these are the steps you do to treat these patients. Most guidelines say, here are your options, pick what you want to do, pick what your patient wants to do, and go with it. So we can treat with high-dose PPIs, swallowed or topical steroids, elimination diets, esophageal dilatations, and now we have biologics available. There are a few emerging therapies. We'll touch very, very briefly on those in the coming slides. So Dr. Seves and some of the other experts in the field have laid out kind of what they view as a way to manage these patients. First and foremost, diagnose. And what do you see next? Allergy referral. Okay. So these patients are going to come in to see us on a regular basis, partly because of these recommendations. But as we'll touch on a little bit, these people have other concurrent allergic diseases. So once we've got a firm diagnosis, how do we treat these patients? Well, there's three things we can do. PPI, dietary therapy, topical steroids. We try something, we repeat the EGD with biopsy. Has it gotten better? Great. You maintain, keep doing what you're doing. If it hasn't, go back up, try something else, or start thinking about other options such as biologic therapy. PPIs in general, most people kind of view these as the first line therapy because they're easy to do, they're cheap, relatively well tolerated, and upwards of 30 to 50% of EOE patients are going to respond to a PPI. So great, that's awesome. We're going to get improvement in the quality of life without having much of a trade-off for that. Pediatric dosing's 2 mg per kg per day divided BID. And for adults, these are kind of the options we have available. Make sure they're doing it right. A lot of people don't remember to take their PPI on an empty stomach, so reinforce that to make sure you're getting a good trial. And because it's a treatment option, if you've got a patient you're referring to GI for a scope, don't put them on a PPI, right? Because that's going to potentially impact the scope results, and the diagnosis is going to be even more confusing at that point. And it's interesting because we're just kind of starting to realize that PPIs work beyond just acid suppression. There's immunosuppression that's likely taking place as well. It seems to be inhibiting eotaxin 3, which kind of drives eosinophils to the esophagus. So it's kind of interesting. Does it impact what we do? No, still put them on a PPI. But in a lot of patients, that's all we have to do. Topical corticosteroids are the next line in many cases. And these studies are all over the place, but in this particular one, 65% histological response, which is generally better than a PPI. There is now a new FDA-approved budesonide oral suspension. It's viscous, so thought is it kind of coats the esophagus better. And it had a 52 response on histological response. With this specific medication, though, after 12 weeks, it seems to lose its efficacy, and I don't know really why that is. So on the FDA reports, you'll see it's to be used for 12 weeks, maybe to get them under acute control, and then you can move on to different managements, make them feel better quicker. With topical steroids, there's no eating, drinking, or brushing your teeth for 30 minutes after dosing. So keep that in mind when you're talking to your patients. There is the risk of candidiasis. So if they're doing well for a while, they're on a swell of topical steroids, and all of a sudden they feel crummy again, and the reflux and heartburn's coming back, you've got to at least think about that as an issue that's going on. And this is a condition where a treatment option will have to continue it long term. If you stop it, that inflammation's going back. Beyond the FDA-approved drug, we've kind of been creative over the years. We've used fluticasone propionates, just the HFAs. We've used budesonide slurries using the respules we typically put in nebulizers, and found ways to treat EOE with these drugs. In studies, there really wasn't much of a difference between these two. Pick the ones you're comfortable with, pick the one your patients tend to like. Next up is elimination diets. And there's a few different ways we can do that. The best way to do it is to go to a fully elemental diet. Response rates 80 to 90%. Works great, but you don't want to be doing this long term, right? Who is possibly going to be drinking these gross amino acid based formulas as their only sustenance? It's not sustainable. You got to put a G tube in. I mean, this is a pretty miserable way to live. So if you're going to do it, maybe you'll do it in an infant and for a short period of time before you move on to other treatment modalities. For a very long time, we tried to use allergy testing to help give us an idea of what the food triggers are, right? Food triggers are an issue in almost all of these patients. How do we figure out what's going on? We tried prick testing, we tried patch testing, and none of it worked all that well. Maybe a 44% positive predictive value. Not awesome. In most experts' opinions that I've talked to, we just don't test these patients anymore. So that leaves us with empiric elimination diets. Basically, pooled data. What are the common triggers for EOE? Where do we start? And by far, particularly in pediatric patients, milk is the most common trigger. So that's a good place to start. In adults, wheat is a pretty common one, so keep that in mind as well. You will find different answers to this based on different studies though, all right? When we're going through empiric elimination diets, there are a lot of different ways you can do it. There's the 6 food elimination diet, where you avoid milk, egg, wheat, soy, peanuts, shrimp, fish, and shellfish. 4 food, 2 food, and even a 1 food elimination diet. Starting with a 1 food elimination diet in one study, 35% response rate, okay, but you're only taking out 1 food, so in a third of patients, that's a great option probably. But then you look at this recent Lancet study that came out in 2023. They really found no difference in clinical or histological remission between a 1 food and a 6 food elimination diet. So the trend over the last few years has been to not do the 6 food elimination diet, which is really difficult for patients to do, is to start with a 1 or maybe a 2 food elimination diet and then expand from there. Because in a pretty sizable percent of patients, that 1 or 2 food elimination diet is going to be enough. So how do we go about doing this? You're going to pick the elimination diet you want to do, and then 2 to 3 months later, they have to go back and get another endoscopy. Not ideal, there's sedation, there's risk involved with that, but it's the only real way to know that the inflammation's gone away. You can't really rely on symptoms all that much. Certainly studies out there that suggest that symptoms don't correlate with eosinophilic inflammation too well. So if you've been on, say, a 6 food elimination diet and it looks good on the repeat scope, you'll pick 1 or maybe 2 foods, put it back in the patient's diet for another 2 to 3 months, repeat the scope, make sure the inflammation hasn't come back, and just repeat that process. So in many of these cases, patients are getting repeat endoscopy, repeat endoscopy, repeat endoscopy, until you've really narrowed down what the triggers are. And one of the more recent advances in EOE is we now have dupilumab as a treatment option. We've talked about it a lot this weekend. It's the anti-IL-4 receptor alpha subunit antagonist. This 12-week study showed significant decrease in symptoms and decreased endoscopic and histologic findings. So you'll see here 60% of patients had histologic remission, and we're also seeing that clinical change as well. I will note for older patients, 40 kilos and higher, we have to bump them up to where they're dosing weekly as opposed to every other week, because when they dosed every 2 weeks, the quality of life scores didn't improve significantly compared to placebo. They did when you're dosing every week. So the dosing is a little bit different for EOE compared to your other conditions. Keep that in mind when you're writing the orders for dupilumab. And of course, you know, the nice thing about dupilumab, I kind of skipped over this, is they don't have to change their diet, right? And for a lot of patients, particularly adults in my experience, they're set in their ways. They don't want to give up the cream of the coffee. They want to eat what they want to eat. This allows them to do that and kind of continue on with their life. But like the topical steroids, you're on this long term. This is something you do, at least for now. And then is esophageal dilatation something we have to do periodically? I've had some patients who just, this is how they treat their EOE. Certainly not ideal by any means. They'll go in, they'll have the stricture opened up with a balloon dilatation. They feel great for a while, but we're not doing anything to treat the underlying condition. That inflammation is still there, their modeling's still ongoing, the stricture is going to come back, they have to go back and do another balloon, feel better for a while, and the process repeats itself. Dilatations are pretty safe for the most part, but you can get esophageal rupture from these things. There are side effects. It's not a great way to go about doing things. There are a few things that we're working on. Anti-TSLP drug studies are ongoing. Looks promising. We don't know yet. And unfortunately, the anti-IL-5 drugs seem to improve the esophageal eosinophilia, but not the symptom score. So I've kind of given up on those as a modality for treating EOE. And then a few anti-IL-3s that may be coming down the road. We don't have a lot of data on those yet. So why are these patients coming to see us as allergy professionals? These are some of the things we talked about here. There's nothing here specific for us as allergists. I'm not going to do the EGD. I'm not the only person who can prescribe a PPI or a solid steroid or guide on food elimination. They can prescribe dupilumab just as good as I can. Maybe our team is better at doing prior authorizations. That could be something. So why are they coming to us? Well, these people are highly atopic. All right. Not only can we help with the EOE management, they have a lot of other allergic conditions at the same time. In some studies, up to 90% of these people have allergic rhinitis. Keep that in mind. Skin testing, I do it for all of these patients. Up to 50% can have asthma, a quarter will have atopic dermatitis, and a quarter will have a coexisting IgE-mediated food allergy. So this is not just an EOE patient we're dealing with, this is an atopic patient we're dealing with. So there's been some data out there to suggest that aeroallergen sensitization, pollens and whatnot, may contribute to some degree on EOE symptoms. I'm not going to go into all the details. These are some of the studies that have some suggestion that there's a role that aeroallergens play. It's not super strong data. In fact, there's, the study in 2013 said symptoms did not seem to vary based on seasons. A meta-analysis showed no seasonal variation of bolus impaction. I mean, that's kind of a tough one, right? Because a lot of these people aren't going to go all that way to that severity. It doesn't really touch on milder symptoms than that. There may be something there, we don't really know, but we need more data, basically. Studies like this are going to be very difficult, though, because in order to really know if there's any role for aeroallergens, you have to do repeat EGDs. And you have to do it during the pollen season, out of the pollen season, and the other thing is symptoms are going to lag to some degree. This is not an IgE-mediated allergy. It's not going to turn on just like that. It may lag by weeks to months, so it's really confusing and difficult to study. So in general, SCIT may improve EOE, but it's certainly not going to hurt. And we're going to make their allergic rhinitis better at the same time. I usually put my patients on SCIT. But I don't put them on SLIT. Why? You're putting this allergen, it's touching the esophagus on the way down. It has the potential to exacerbate the EOE, make things worse. And studies looking at some of the dissolvable tablet formulations do suggest there is worsening of EOE if you use them. The other potential role that we as allergists can have in this is using other modalities to track symptoms. There is now a commercially available esophageal string test, brand name is EnteroTrack, which may allow us to monitor disease without having to go back and do repeat endoscopies. This is basically a string, and I'll show you pictures in a second. Put it in the esophagus, have it hang out there for an hour, and it kind of absorbs various eosinophilic associated proteins, all of these here, that have correlated with biopsies pretty well. Results are pretty promising. So you'll send off this string, we'll measure for these eosinophilic proteins, and we can have a pretty good idea of if what we're doing is helping. Not to be used for diagnosis, still have to do a biopsy for that. This is just for management long term. So this is what it looks like. It's a little capsule with a string hanging out. They will swallow this pill, making sure to hold on to one end so you don't swallow the whole thing. Tape it to the side of the face, and they hang out for an hour, you know, watching YouTube or whatever they're doing. That, over that hour, this bead will just fall off. It passes without any problems. So it's just the string that's left behind. So then you'll retrieve the string, you'll pull it out, and you'll use this little pH marker. Basically, it will change color when it hits the acidity in the stomach, so you know where that duodenal junction is. And then you put it in a little vial and you send it off to the company, and they will measure these markers for you. So handy. I think it's something that maybe we can potentially use in our clinics. Finances have to be worked out. When I spoke with this group not too long ago, they're actually going to charge us for this kit. So it doesn't make a lot of financial sense for us to do this. There's no codes for it or things like that. But if those things work out, it may be something that we can do to really start helping our EOE patients without repeat endoscopies. Okay, questions? Yes? Yeah. So it's tough, right? I think it depends a little bit on how they're doing. If clinically they're a lot better, you could have this conversation with the patient. You're better, you're on this PPI. We don't really know exactly what's going on, but maybe you could just keep them on the PPI moving forward. It's an option. Me personally, I want to know the diagnosis. If they've had true dysphagia, I'm probably going to tell them to stop it and then get into CGI. It's going to be 3 to 4 months before they can get into CGI anyway. That should be enough time to see return of that eosinophilic inflammation and get a good biopsy. But there's no right answer. I don't know that for sure. 12 weeks, is that long enough? Yeah, I don't know that's been studied, but.
Well, maybe this allergy should be involved. GI doctors are the worst at explaining this disease. Patients have brought the results to me and say, I have no idea what I have.
Yeah.
I don't know what it is.
Well,
they'll scope the patient who wakes up on propofol feels like Michael Jackson, and they're giving them the whole medical spiel, you know.
Yeah, absolutely. And they come in saying, oh, my GI doc wanted me to get allergy testing.
Right.
And you know, and that's a whole other conversation you have to have with them. I don't know why that data hasn't moved into the GI realm. Like, I think maybe because they don't want to manage these patients. Like, move it off to the allergist.
They can pay the scope.
Yes, that's how they. Yeah. So it's just it's a long conversation with these patients. There's a ton of things to go over. You have to talk about the treatment options outside of just what this condition is. So it's not easy. Look, I'd be lying to say if I didn't. You know, I do this occasionally to make the patient happy, to make the GI happy. But I always say beforehand, this is not a great test. I make that very, very clear before we do any skin testing. This testing is designed for anaphylactic reactions. This is an anaphylaxis. It may help to some degree. Let's see what shows up. So just be very clear with the patients before you actually do the scratch test.
How are you handling, and I don't know if you've seen this, but I've had a patient recently who was doing better. They had had the hemophilia and they were doing well symptom-wise, but when they re-biopsied, their symptoms had gone up. And so then they were sent to us.
Yeah, that's tough to do. None of these things are 100% response rate, right? Yeah. So are there different food triggers now? Have things changed for whatever reason? We have to obviously look at compliance with drugs. That's a big one as well. There's a lot of factors, and sometimes you just have to start from scratch, which is not ideal for them. But adding on more to what they're already doing is not ideal, but sometimes what you have to do. Or in that situation, I would certainly think about a dupilumab as an option if they're not on it already.
But everything else fits. In the past, I just treated her for 50 years, but if they're now immune tested, something that was
Nothing that's being used regularly. It still comes down to the biopsy. First thing I would do is check to see how many biopsies were done.
Yes.
I've certainly seen where there's like 2 biopsies done or 1 even, and you have to go back and do it again, right? So that's the first thing I would think about. And then the other is, are they taking a PPI at home that wasn't prescribed? So these are all over-the-counter medications, right? So that might be skewing things as well. And then sometimes even if you do 6 biopsies, maybe you miss it. Because like I said, this is patchy infiltration. It's not uniform. It may take another scope to pick it up. Yeah. Yeah, I don't know that that's been studied to any rigor. Probably don't need to be a year. Like I would probably have them off for 3 to 6 months, something along those lines, before you start. Yeah, exactly.
Piggyback on that, in the presentation I was giving researching it, 2 weeks off for symptomatic relief, 4 weeks biopsy.
Perfect, thank you. Okay, anything else? All right, perfect. Thanks, everybody.
Okay. All right, so let's get started. We've got a couple speakers here, and then we'll break for lunch. Our next speaker is a friend of Dr. Weibel, so we won't hold that against him. Oh, that might be stretching a little bit, right? Dr. Crisp completed his internal medicine and allergy immunology training in San Antonio, Texas. And after serving 8 years on active duty with the U.S. Air Force, he came to Dallas and joined North Texas Allergy and Asthma Associates. He's going to be speaking with us about immunodeficiency, workup, and where and when to refer to an academic center. And so please welcome Dr. Crisp.
All right. So I'm Howard Crisp. I'm an allergist here in Dallas, and I have a fairly broad topic of immunodeficiency workup and when to refer. I don't have any disclosures for this talk. I'm gonna actually walk down, I think. So I'm gonna go over a basic review of the immune system, when to consider an immune deficiency, basic evaluation for the immune deficiencies, and then a few selected conditions. So just to remind you all, our immune system has both innate and adaptive parts. The left side here is our innate immune system. So you have epithelial barriers, so skin linings, mucosal linings. You have phagocytic cells, so neutrophils, eosinophils, macrophages. You got complement and NK cells. Then you have your adaptive immune system with your B cells that produce antibodies and your T cells that become effector, helper, and cytotoxic T cells. To help you remember, so the B cells produce antibodies. Those help to neutralize microbes, facilitate phagocytosis, facilitate complement activation. Your helper T cells will stimulate parts of the innate, will produce cytokines to stimulate parts of the innate immune system. So they can stimulate eosinophilic inflammation, neutrophilic inflammation, and then activate additional T cells and B cells. Your cytotoxic T cells will help kill infected cells, and then your regulatory T cells help suppress immune responses. For your B cells, when you have a mature resting B cell, they're kind of just hanging out. But once they're exposed to their antigen that they're specific for, especially with T cell stimulation, they'll expand, and then you'll get plasma cells that produce IgM. Later, you'll get isotype switching, where cells will produce IgG or other antibodies. Over time, you can get affinity maturation, so the IgG antibodies become more and more specific, bind more and more tightly. And then you'll have memory B cells that help you respond to future infections. Again, just briefly, so primary antibody response is going to be mostly IgM production. And then as you clear that infection, you'll have memory B cells. When you get infected again, you'll have a more robust response, producing predominantly IgG antibodies, and then again having some plasma cells that will live in the bone marrow to produce more continuous IgG, and then memory B cells that'll again help you respond in the future. So when should you think of an immune deficiency? So this is from the Jeffrey Modell Foundation. These ones here are for children. So if they have 4 or more new ear infections within a year, 2 or more serious sinus infections, 2 or more months on antibiotics without real benefit, 2 or more pneumonias within a year, failure to thrive, so failure to grow or gain weight normally, recurrent deep skin or organ abscesses, persistent thrush or fungal infections, the need for IV antibiotics to clear infections, 2 or more deep-seated infections, including things like sepsis. And then obviously, if they have a family history of a primary immunodeficiency, you want to think about that. For adults, it's really very similar. Adults don't get ear infections as often, so 2 or more ear infections, 2 or more new sinus infections within a year, especially in someone who does not have allergies. 1 or more pneumonia per year for more than 1 year. Chronic diarrhea with weight loss can be a sign of an immune deficiency. Recurrent viral infections, recurrent need for IV antibiotics. Again, deep abscesses of the skin, persistent thrush. Infections with normally harmless bacteria should make you think of an immune deficiency. And again, if they have a family history of an immune deficiency. The type of defect they have will sort of guide the infections that they have, or kind of backwards, you can think of the infections they have and what the defect is. But if they have immunoglobulin or complement defects, they're going to primarily have sinopulmonary infections and gastrointestinal infections, and then bacteremia and meningitis. Strep pneumonia or Haemophilus influenza are going to be the most common, and then Neisseria, especially for complement deficiencies. If a patient has a neutrophil defect, they're going to have invasive skin and soft tissue infections, especially abscesses. T cell defects tend to lead to viral, fungal, and then opportunistic infections. And then if they have immune dysregulation, they're going to have kind of autoimmune manifestations and then combined defects depending on what parts of your immune system is affected. So I'm going to give you some basic labs to evaluate the immune system. This is not going to be a comprehensive list of all possible tests. For the innate immune system, a CBC with differential is certainly the most important one. This will give you your neutrophils, eosinophils, monocytes, and basophils. For certain conditions, you may need to check this more than once. So if they have like cyclic neutropenias, you're going to have to check it again. If patients are on steroids, you'll need to check it again when they're not on steroids. But that is very important. And then if you're worried about a complement deficiency, a CH50 is the main test you want to check. This will basically essentially test complement components 1 through 9. If they have a homozygous deficiency for any of those, they'll have an undetectable CH50. This test is heat labile, so if you get a low test, I would certainly repeat it. I'll usually have patients go back to the lab on a Monday or Tuesday to reduce the chance that the test gets left out somewhere over the weekend. And then you may see an elevated CH50, so a CH50 greater than 60. This really does not have any specific clinical meaning. It could be a marker of inflammation, but generally I just view it as normal. Additional tests you might do in selected patients. So the dihydrorhodamine 1,2,3 test is for NADPH oxidase for chronic granulomatous disease. So they're going to have neutrophil defects. And then if you're highly suspicious for complement deficiencies, such as recurrent meningitis, you can also get AH50, which tests the alternative complement pathway, but deficiencies in that are really quite rare. For the adaptive immune system, the most important part is going to be your immunoglobulins, so your IgG, A, M, and E. These are very easy to order at all labs. Flow cytometry can also be important, so just a basic series that'll check your T cells, B cells, and NK cells. We'll get into some vaccination testing later, but tetanus and diphtheria antibody levels will let you assess basically protein-based vaccine responses to tetanus and diphtheria vaccines. Some labs will call these antitoxoid antibodies. And then pneumococcal antibody levels are also important. Depending on what vaccines the patient has received, it can either be assessing a protein or polysaccharide immune response. So that can make it complicated to interpret, which we'll touch on later. And then it's not a primary immunodeficiency, but an HIV test is always good if you're worried about an immune deficiency to rule out the acquired immune deficiency. So additional tests you might do in selected patients. So lymphocyte proliferation panels, there's mitogen panels that will just non-specifically stimulate lymphocytes to cause them to proliferate. And then antigen panels, like principally Candida, which will evaluate memory and cell-mediated immunity. IgG subclasses are also very easy to order, but isolated deficiencies in IgG subclasses are probably not really clinically relevant, but they can be useful to kind of more broadly phenotype a patient. And then genetic tests are also now fairly readily available. There's small panels, there's large panels, but these can be helpful if there's a patient that you're worried about. So for most low suspicion evaluations, I get a CBC with differential quantitative immunoglobulins, and then IgE, often as part of a respiratory profile. So this is going to be like in an adult who has recurrent sinusitis or recurrent bronchitis, but not really any other real suspicion for an immune deficiency. So I'm just going to go over a few selected conditions. So severe combined immunodeficiency is something we should all be aware of. It affects about 1 in 60,000 births, and it's caused by any number of gene defects that impair T cell development or function. Those gene defects can directly impair B cells and NK cells, but any severe T cell defect will also preclude effective B cell activity. In the past, they've been classified as T negative and then B positive and negative or NK positive and negative, but now preferentially they're classified by the specific gene defect the patient has. So most infants diagnosed with SCID are going to appear healthy in their first months of life because they're partially protected by maternal antibodies that have come across in the 3rd trimester. As they get older, they'll get progressively severe infections, diarrhea, and failure to thrive. And without treatment, most of these patients will die by the age of 2 years. If they are treated before they develop any serious infections, the long-term survival is greater than 90%. Stem cell transplant is the most common definitive treatment. And there is newborn screening for this in all 50 states now. There are some uncommon cases, things called leaky skid that can be missed. But most patients, if they're born in a hospital, are going to be screened. And then again, most infants are going to be well appearing when this is done. Newborn screening started in the United States in Wisconsin in 2008, but since 2018, it's now in all 50 states. So the newborn screen, just to kind of let you know, it's taken from a heel stick that's used to screen for this and multiple other conditions. They check TRECs, which are T-cell receptor excision circles, and the number of TRECs in the sample reflect the number of T-cells in the blood. Roughly half of patients with low TRECs on their initial screen are going to be confirmed to have a T-cell defect, but most of the other cases are also going to have a identifiable cause, so like severe prematurity or other genetic defects. So all patients with an abnormal screen or other suspicion for SCID should be referred to a center capable of further evaluating them. This is just to kind of emphasize on the left, if a child with SCID gets their stem cell transplant before they get any infection, their odds of survival are greater than 90%. And then after they start to get infections, it drops to about 80%. And then on the right is the odds of survival depending on their transplant match. So if they have a matched related donor, they have essentially 100% survival. And if they have mismatched or less matched donors, their survival decreases. So again, these are patients that should go to an academic center that can confirm the SCID diagnosis, help them find the appropriate donors. So now I'm going to change gears completely to things that are a little bit more manageable. Selective IgA deficiency. So this is a particular case I saw. A 30-year-old woman referred for undetectable IgA on a panel that she had done for celiac disease testing. She has frequent abdominal pain and bloating. She had normal colonoscopy. She reports 1 or 2 sinus infections per year that resolve without antibiotics. And then she has normal immunoglobulins except for a low or undetectable IgA. She also has a normal CBC with differential and normal flow cytometry. So selective IgA deficiency is an absent IgA with normal IgG and IgM without identifiable cause. It is the most common primary immunodeficiency, affecting around 1 in 400 patients, but the majority of these patients are asymptomatic. Some will have sinus or GI infections, some will have autoimmune diseases, some will have allergic conditions. But in general, there is no specific treatment required for this. They should receive all routine vaccinations. There is a little bit of a caution with live vaccines because they're not explicitly studied in these patients. You should treat their concurrent conditions. So if they have allergic rhinitis or chronic sinusitis, those would be treated. If they do still have frequent continued infections, they may need prophylactic antibiotics. Immunoglobulin replacement, in my experience, is really not indicated for most of these patients. IVIG or sub-Q immunoglobulin replacement does not replete their IgA levels. So if this is their only sort of immune defect, generally they're not going to need that. So a different case that you're also likely to see. So this is a man in his 60s with frequent sinusitis over the past year. He's had multiple courses of oral steroids and antibiotics. He had a sinus CT that showed prior surgery and multiple areas of mucosal thickening with frothy secretions and air fluid level. He had slight positives on allergy skin testing and blood testing to a few pollens that didn't really correlate with his symptoms. He got a CBC with differential, that was normal. Total IgE was normal, but you see his IgG and IgM are both low with a normal IgA. So the first thing I do is repeat it, make sure it's accurate. In this patient, I went ahead and also got an SPEP, that was, or a serum protein electrophoresis, that was normal except for hypogammaglobulinemia. I obtained IgG subclasses just for interest, and 1, 2, and 3 were low. He had normal flow cytometry, and he had protective levels to tetanus and diphtheria. His pneumococcal titers were relatively low, so I use 1.3 or greater as the kind of protective level, or what should be a normal immune response after vaccination. He only had 3 levels that were greater than or equal to 1.3. So I had him get the pneumococcal polysaccharide vaccine to check his polysaccharide antigen response. And then after the vaccine, 9 of the 23 were greater than or equal to 1.3. And then of all of his titers, only 9 of them doubled. So an adult male with recurrent acute and chronic sinusitis, low IgG and IgM, and a poor response to pneumococcal polysaccharide vaccine. What do we think the diagnosis is? CVID. Yep. So CVID is the most common symptomatic primary immunodeficiency. It affects somewhere around 1 in 25,000 people. Most commonly diagnosed in adults between 20 to 40, but there is really a broad age range for this. The diagnosis is often delayed by a number of years, and it affects both men and women roughly equally. It's defined as a low IgG on at least 2 occasions, 3 weeks apart, also with a low IgA or low IgM, impaired antibody responses to either T-dependent or protein vaccines, namely we're going to use tetanus and diphtheria, or T-independent or polysaccharide antigens, mainly we use the pneumococcal polysaccharide vaccine. And then other causes of hypogammaglobulinemia should be excluded. Greater than 90% of these patients have infections as their primary clinical manifestation, but some will have autoimmunity and some will have lymphoproliferation. Flow cytometry is not strictly required for this condition, but it can be helpful. And then there are some labs that will do memory B cell subsets, and particularly if they have low isotype switched memory B cells. So these are CD27 positive, IgD and IgM negative. That goes along with CVID. Genetic studies are not required, but they can be helpful in certain cases. And then one of the important things you want to do is rule out secondary or alternative causes of hypogammaglobulinemia. So anti-CD20 antibodies are by far the most common secondary cause of hypogammaglobulinemia. Rituximab's been around a long, long time to treat a variety of rheumatologic conditions, but there's others that are out there now, treat multiple sclerosis and other autoimmune diseases. These can cause a very severe hypogammaglobulinemia in some patients. Anti-seizure medications are also somewhat common, and I have seen. Sometimes these are used to treat seizures. Sometimes these are used to treat mood disorders, but these can also cause hypogammaglobulinemia. And then long-term, especially high-dose glucocorticoids can cause this. Malignancy, especially hematologic malignancies, are also common causes of hypogammaglobulinemia. Chronic lymphocytic leukemia will very commonly have low IgG levels, and then other lymphomas and myelomas can cause it. Less common things, but HIV can cause it, congenital rubella or CMV can cause it. Anything that causes you to lose a lot of protein, so that can include nephrotic syndrome, where they're urinating out a lot of protein. If they have very severe burns, like they're in a burn unit, or if they have protein-losing enteropathies. And then other specified immune disorders. So if a patient has severe combined immunodeficiency, they can have low gamma globulins. If they have hyper IgM syndrome, they can have low IgG and low IgA. And then there's a condition, thymoma, with hypogammaglobulinemia that's uncommon but can be seen. So for the vaccine responses that are part of this condition, you want to ideally test both protein and polysaccharide responses. Protein responses require both intact B and T cell function. Polysaccharide responses really require a B cell function only. Ideally, you want to do a pre-vaccine check and then again check them about 4 to 8 weeks later. And if they don't respond normally, the two patterns you'll see are either they failed to respond to the polysaccharide only, or they failed to respond to both types of vaccines. For the protein vaccine, again, we use tetanus and diphtheria. A protective level is going to be for diphtheria between 0.01 to 0.1. Tetanus is greater than 0.1 units per mil. Levels well above these are normal. Levels that are low or borderline, so if they're at like 0.2 or 0.3, I'll have them still get the vaccine and recheck their titers. You just want to use the age-appropriate vaccine, so for most adults, it'll be TB or Tdap. For pneumococcal polysaccharide responses, so these should not be used in children under 2. Pneumococcal polysaccharide vaccine is the primary vaccine used. Testing should include a panel of 14, or I would really recommend 23 serotypes. And then again, levels greater than or equal to 1.3 micrograms per mil are considered normal. To focus on the moderate line there, on the greater than 6-year-old side, so greater than 1.3 for less than 70% of serotypes would be sort of a moderate deficiency. There is some debate, maybe 50% is normal. It's a little bit hazy. Certainly less than 50% is abnormal. And if it's only 0, 1, or 2, that's a very severe abnormality. On the milder side, they can respond to more than 70% of serotypes but have a less than 2-fold increase. But if they have high pre-vaccine titers, they're less likely to have a substantial increase. So that also has to be sort of taken with a caveat. On the bottom, there's the memory response. So some of these patients will lose their antibodies within 6 months. So for me, most of the patients who are in that little bit of a hazy range, maybe they respond to 60% of their types, I'll wait 6 months and recheck. And if they drop, that really reinforces me that they have an abnormal immune system. Now, the increasing use of protein conjugate vaccines does complicate the interpretation. Patients who have had pneumococcal conjugate vaccines should generally have those titers excluded when you are assessing their polysaccharide antigen response. So on the top here, these are all the serotypes in pneumococcal polysaccharide. There's one on the very end that's not in that one, that is in the conjugate vaccines. But you see, as we've gone along and gotten up to PCV20, there's only 4 serotypes left that are not covered by PCV20. And then I don't have on here, but there's now also PCV21 approved. The bottom, some of the ones basically on the left are actually not in PCV21. And then it has some extra ones that are not in any of those vaccines. So again, knowing exactly what they got is important. You can't just have a patient tell you, oh, I got the pneumonia vaccine, 4 weeks ago, and expect that it's the pneumococcal polysaccharide vaccine. So once you have a patient diagnosed with CVID, the principal treatment is immunoglobulin replacement. It can either be IV or sub-Q. Typically a dose somewhere between 400 to 600 milligrams of gamma globulin per kilogram of patient body weight. This will reduce the number of infections, the antibiotics they get, and the hospitalizations they have. You do want to check a trough IgGs somewhere between every 3 to 6 months. After I start therapy, I usually check it around 3 months. And then you also want to monitor them clinically. Most patients, this is what they need. There are some patients that will need prophylactic antibiotics. Most of these patients should still get non-live vaccines. They'll all ask me, I don't respond to vaccines, why should I get them? So if they do respond to protein vaccines, most of the vaccines we have are protein vaccines, so they'll respond to those. And then even if they don't, they may have T-cell responses that we don't really have commercial ways to measure. So as long as it's not a live vaccine, I will generally have them get anything that would be recommended for their age or other comorbidities. They will often need multi-specialty care for their complications. So bronchiectasis is pretty common, and I'll usually at least consider getting a chest CT at the time of diagnosis. And then some patients will get like autoimmune cytopenias, so you may need to co-manage them with pulmonary medicine or hematology. A sort of milder deficiency, so specific antibody deficiency, is an inadequate response to the polysaccharide-based vaccine only. So normal responses to protein vaccines, normal immunoglobulins, no other confirmed immune system abnormality. Some of these patients may have an IgG2 subclass deficiency, and some people like to use that diagnosis principally. But usually, as part of diagnosing the IgG2 subclass deficiency, they're going to confirm that they don't respond to these vaccines. But patients with specific antibody deficiency typically have severe recurrence, sinopulmonary infections. The treatment, because they don't respond to polysaccharide vaccines, is to have them get conjugate vaccines. You want to treat any concurrent disorders. So if they have allergic rhinitis, they have asthma, you want to treat that. You want to just be more vigilant against infections. Some patients will need prophylactic antibiotics. I kind of look at how often they're getting antibiotics to help guide that treatment. And then some patients will need immunoglobulin replacement. So IgG subclass deficiency by itself is a somewhat controversial diagnosis. Most patients with low IgG subclasses of only one type with a normal IgG are going to be asymptomatic. If they're symptomatic, they're going to have sinopulmonary infections. IgG2 subclass deficiency will often cluster with an IgA deficiency and an IgG4 deficiency. And for it to be clinically significant, they really should fail to respond to polysaccharide vaccinations. And then the treatment really overlaps with specific antibody deficiency. So cases that probably do not need referral to an academic center are going to be selective IgA deficiency. If they have specific antibody deficiency or IgG subclass deficiency, especially if you can do the pre and post vaccine testing, you probably don't need to refer them. We have found it's difficult to get pneumococcal polysaccharide vaccine through most of our pharmacies. So we've just taken to ordering it directly, and we give it in our office and bill it out. And then we do our labs, most recently through Quest Diagnostics. For CVID, again, if you can do the pre and post testing, and if you can order immunoglobulin treatment, which can either be at home or at an infusion center, then you can likely manage these patients, but they may need subspecialty consultation for other conditions. So when should you refer? So all cases of SCID or suspected SCID should be referred right away. Most young children with a confirmed or suspected immune deficiency, I would refer. We don't draw blood in our office, and most of the commercial labs I've sent children to, they've had really bad experiences. So if there's a child that needs especially recurrent blood draws, I'm going to refer them to a pediatric specialty clinic. And then if there's a condition that you just don't feel comfortable managing, you can refer them. So even if you're doing everything right, second opinion can be helpful. If you've never seen the condition before, it's probably worth referring. And if you refer a patient, it does not mean you have to stop treating them. So if you're treating their allergies, you can still refer them for their immune deficiency, or you can still treat their immune deficiency and just get a second opinion from another place or an opinion to help kind of guide you. Doesn't mean you don't have to see the patient anymore. So these are some resources. So the Immune Deficiency Foundation has lots of resources for both providers and patients. The Jeffrey Modell Foundation has lots of materials and posters in different languages. And then the Joint Task Force on Allergy and Immunology Practice Parameters has practice parameters for us. And that is it. Any questions? Hopefully I didn't go too quick. Yes. Yeah, so as of now, we have not had trouble ordering it. I think we order it through McKesson. But once it's gone, I don't exactly know what we're gonna do. There are some people looking at typhoid vaccinations. Quest does have a typhoid vaccine lab that's sort of qualitative only. I think it's like positive, negative. There is a lab in Wisconsin maybe that does more quantitative titers. Eventually, we may need to look at something like that. I've also had patients, well, one patient who I was pretty confident had CVID because he had tons of recurrent sinus infections, lung infections, bronchiectasis, low IgG&A. But his pulmonologist gave him PCV20 4 weeks before he saw me, and he had relatively good responses to that. So I diagnosed him with hypogammaglobulinemia, and you can get IG covered for that diagnosis. Hopefully I won't have to do that too much into the future, but yeah, I imagine typhoid might be what we start to use in the future. Yeah. Any other questions? Mm-hmm. Normally I use azithromycin, like 250 milligrams, Monday, Wednesday, Friday. Yeah. Anything else? All right, well, thank you for having me.
All right, I meant to ask this morning, how many of you made it to Billy Bob's last night? How many of you rode the mechanical bull? They don't have any more? Live bull. How many of you did that? No? No? I could have sworn you would do that. All right. Our next speaker is going to talk to us about interpreting weird spirometry. I'm really looking forward to this. Kevin Collins is an associate professor of respiratory care at Texas State University, the Round Rock campus. He has taught in the Bachelor of Science Respiratory Care degree program for 17 years. In addition to his PhD in adult education and Master of Science degree in respiratory care, he holds credentials as a certified asthma educator, registered respiratory therapist, and a registered pulmonary function technologist. Please welcome Dr. Kevin Collins.
I'm gonna make sure I'm on. Y'all can hear. Okay, let's talk about spirometry. Some may be weird, some may not be weird. As soon as I can operate this, here we go. Here are my disclosures and our objectives. Let's see if you can learn a little bit about spirometry, recognize some components of the American Thoracic Society guidelines spirometry testing. So if the rest of this talk, I'll be saying ATS a lot. Are y'all familiar with ATS? Classify normal versus abnormal spirograms and identify some strategies for spirometry interpretation. So pulmonary function testing is a broad name for a lot of different tests. I always joke with my students, and you're in the hospital, would you ever say, hey, the doctor wants to order a blood test. I need a blood test. Like, which one? There's hundreds of them. I need a pulmonary function test. Which one? There's a lot of them. So spirometry is the first line test, and then especially if we get in restrictive disorders, you'll need to send like to a hospital lab for lung volumes testing and such. So I had one of my students do a video doing one maneuver of a spirometry effort. She's seated. I'm going to put nose clips on her. She has a handheld spirometer. So just keep in mind when your patients are performing spirometry, you probably need to make a note if they're seated or standing. And each time they return, they should be in the same body position to do that. So I'm going to hand her the spirometer. It's already been zeroed out. This is her actual effort over here to the right. So you should see in real time their flow volume loop and volume time curve when you're performing the test. That's the ATS guidelines, because what we're looking for are technical errors. So through this presentation, I need you to think, when I'm showing these examples, think normal, is this a technical error, or is this pathology, that what's going on? Because it can be confusing. So this is a good example. My student Emily did a great test. She reached a plateau. So ATS says you need to do at least 3 efforts or maneuvers like this, minimal, that are acceptable and repeatable, up to 8, right? So here's a common way. And there's different ways, depending on your spirometry system, how you format the final report as you see it here. So we have the measured values, the actual values, the indices over here to the right, the actual measured values, the lower limit of normal. So what I'm going to teach you, and currently what the ATS says for lower limit of normal is using Z-scores, which is on this bell curve. We'll talk more about that when we get to that. So, but on the final report, it may look different on your spirometry reports. Now, if you're not, how many are used to seeing, do y'all have Z-scores formatted for your final report? If you don't, sometimes your system, you have to go in and tell it, show Z-scores. And we'll talk about that. But you do want the flow volume loop and the volume time curve showed on there. Now this has ULN for upper limit of normal. This is a screenshot of a full PFT. We don't need that for spirometry. We don't care if they have abnormally high spirometry. We don't care. We want to know what the lower limit of normal is if it's abnormal. So this is some indices. This is the way I would recommend if you guys formatted your final report to show these values on here. So we know that ATS says all you need for interpretation is FEC, FEV1, and the ratio of the two. Now there's a lot of other indices on there. It can be helpful for other interpretation, but as far as is it normal to have areas of obstruction, a suggestive restriction, or a mixed pattern, you need those 3 variables and that's it. But I would encourage you to include these others, and we're going to talk about some of these. So this includes expiratory measures and inspiratory measures. And it'll be important to understand why we need the inspiratory measures. If you're not familiar with this article from the ATS, 2019, they updated the guidelines on how to perform spirometry. Before that, it was 2005 before they updated, so it was a long stretch to be updated. There's many things in here about pre-test procedures. We're trying to get acceptable, repeatable results. So anything like the doctor was saying before, he ran a lab test, didn't know if it was accurate, or ran it again. Well, we want to look, same thing if there's any technical errors, but we want to make sure we're getting our patient's measurement. Do we get their age right? We measure their standing height. We ask now ATS says sex at birth. So it kind of sounds weird, right? We don't ask their gender anymore because of this day and age, but we want to know because their predicted lung values will be based on their birth. If we're going to predict what their normal lung function is, we need to know what their gender was at birth or their sex at birth. Calibration verification, very important. BTPS correction. We want to know what the volume of air is inside the lung. When you exhale into the room air, the air is cooler. The volume's going to shrink. So the spirometer has to calculate what the volume originally was inside the lung. And how does it do that? By you inputting the room air temperature, the relative humidity, and the barometric pressure, which all have a factor in lung function testing. So I can't say this enough, training experience. It's not just pushing buttons. There's a lot to it. And I stole this quote from Dr. Weingarten. He's our attending physician for the pulmonary fellows at UT Dell Medical School. He said, ignore these standards at your own peril if you're not following these. Okay, accuracy versus precision. Everything in science, engineering, medicine, any kind of diagnostic device, you want to make sure what you're getting is accurate, right? What are we supposed to be measuring? Accuracy, volumes and flow rates. Is it precise? Can we repeat the same measure? We're talking about within one patient performing. Can we get about the values close together, meaning volumes and flow rates and such? So I like to use the example of a stadiometer for measuring height. So say someone installed this stadiometer, it was 3 inches off. And nobody figured that. This actually happened in one of the pulmonary clinics in Austin. one of my faculty was doing a research studies at this pulmonary clinic. Said, hey, your stadiometer, it's off by like 2 inches. They go, what? They go, yeah. I mean, you need to get that fixed. So would it be accurate if it's off by 2 inches? No, it's not measuring what it's supposed to measure. Is it precise? Yeah, because everybody comes in there, it's going to be 2 inches shorter than they're supposed to be. So it's very precise, but right, you got to have both together. So if you don't have accuracy and precision, garbage in, garbage out, and you guys as providers, forget about interpreting results because you're not going to get anywhere. So who's conducting spirometry testing in your clinic? It's a good question. Let me say this. Spirometry testing, it's not a task. It's a diagnostic test. Okay, you just can't put anybody in there. Just do it we have trouble with this. I've trained many physicians, respiratory therapists, NPs, RNs, MAs, people off the street. I teach a NIOS spirometry course. I got people from the oil field in West Texas. They can't even pronounce spirometry. I'm supposed to train them. So there's a lot to it. It needs formal training. So keep that in mind. So let's look at, these are not from a real patient. These are just illustrations. When you look at volume, the flow volume loop, they're on the left, and the volume time curve, can tell you a lot of information, even without looking at the numerical data, right? You can see a lot, meaning you can do an interpretation, you can see if there's a technical error, what did they do? So anything on the flow volume loop, anything above the horizontal line is expiratory side. That's when they're breathing out. Below the horizontal line, inspiratory, right? We want them to breathe in to total lung capacity. How do we know they're at total lung capacity? How do you know if they're, you say, take a full breath in. Well, it's funny because in the ATS, in that article I showed you, they say, if someone looks normal, they don't look uncomfortable, they're not at TLC. They're not there. When you breathe in, their eyes should get wide, their eyebrows raised, their head should be quivering. Okay, then you can tell them to blast the air out. But before then, if they're comfortable, they're not at TLC. So if we can only measure as much air as they can breathe in, their vital capacity is going to be low, artificially low, then your ratio is going to be off. And you guys as providers are not going to be able to interpret it. So this is from an up-to-date database showing some abnormal. We got normal on A. We can see it's a good flow volume loop. B there, has anybody seen anything look like that? So the inspiratory loop that's flattened, extrathoracic outside the lung, and we'll talk more about that. Then we have C, variable interthoracic, some obstruction inside the lung, fixed airway obstruction that could be inside or outside the lung, and then very familiar with the lower airways obstruction like we see in asthma or emphysema and many other obstructive diseases. So here's the illustration, and then beside it is a real patient. This coincidentally, last month in our spirometry training course, I had a 20-something-year-old guy, and I was looking at a spirometry and said, wait, I'm going to keep that. So I did a screenshot. So this knee or shoulder, as it's called, and you can see it on this actual person that did it in B, is a normal variant. We need to know, is that normal? Is that a technical error? Is that pathology? No. Well, let's consider the age of the individual. Well, if I see this, I'm thinking, oh, that's probably a normal variant due to their age for that patient. So keep that in mind. OSA, showing some of that collapsibility in the upper airway. Now this would probably have to be, probably on the severe end to see this actually in actuality. So this one, I'm going to play this animation. So this is a normal flow volume loop for D. When you see the red line come up here, so I pretend like, okay, there's the patient effort. So you see let's see if I can get my pointer here. See where this end, this is supposed to match. This is the end of the effort. It's supposed to match the other line. So this is the expiratory side. They're at residual volume. Breathe in real deep right here. Why didn't those match? Does anybody know why? This is a real problem. If those don't match, you're in trouble. So it didn't match because they didn't fill their lungs to full TLC. And they measured, that's why the inspiratory is larger than the expiratory side, because they didn't fill their lungs. Now sometimes it's us, the operator, performing the test. Did I turn it off? And sometimes it's a patient, we have to coach them. You know, eyebrows raised, eyes wide open, their heads quivering. Okay, now blast it out. We can only measure as much air. So this was not listed in the 2005 guidelines. In 2019, they finally listed this as a technical error because this can be a problem. So make sure if you're doing, are y'all doing flow volume loops or just the expiratory side? I mean, hopefully you're doing no flow volume loops. Okay, so that's suboptimal inhalation. They didn't reach total lung capacity before they were instructed to blast the air out. So here's we got normal here. This is pretty severe obstruction. This would probably be a patient with pretty severe emphysema. So the way I like to look at it is, it almost looks like a chair. It's so flat on their flow there that you could almost sit in a chair and lean back on that, right? That's severe obstruction, very severe. Let me get my pointer to work. It's not wanting to move. Oh, there it is. So restriction. So for spirometry in general, we can't confirm lung restriction. We usually have to send to the lab, the hospital, do plethysmography, a body box study to confirm restriction. But this is pretty obvious. If you follow the little dots, that's their normal and their predicted lung volume. If you follow out to the end there, it's about 5.5 liters for their normal volume. And this is measured but a little over 2 liters. So that is a very reduced, and it has that very characteristic tall, skinny. So if a flow volume loop, the volume is side to side, right? The skinnier it gets, it's more restricted. That means those two volumes, FEV1, FEC, are going closer together, so their ratio is going to increase, right? It's just math. If two numbers get closer together, approaching 1, you express that as percent, it's going to get bigger. So that's another indication that. So extrathoracic upper airway, so this is going to be right in the larynx. Probably could be time for the ENT referral, right? Maybe vocal cord dysfunction. We see this a lot, but this could also be suboptimal effort. So when we do a flow volume loop, expiratory is forced and inspiratory. So it's a forced expiratory and inspiratory maneuver, both. If we don't do forced inspiratory, you might get this flattened curve. We don't want to unnecessarily refer someone to another specialist if they don't need to go and waste their time and maybe misdiagnose them or something. So that's helpful to know. Okay, we're going to get into interpretation. I didn't come up, when you see this, I didn't come up with this, but one of my faculty members found it. But I think it's true. It's true. It can be very true. If you think about it, in your case, as a provider, you can think about this. Okay, so another guidelines in 2022, the ERS, so ERS, European Respiratory, that's the European counterpart to the ATS, came up with some standards on interpretation strategies for PFTs. Very, very good document, very well written. I recommend it. Okay, like I'm talking about spirometry, why I have 12 lead EKG, because I need help. I need you to interpret this for me. Any ST segment changes, they an AFib? No. I mean, if you saw that, what are you going to do? What's a cardiologist going to do if they see that? Well, they're going to have a fit. They're going to go, who did this? Get back in there. I need another 12 lead. I can't interpret that because there's too many technical errors. Wavy baseline. Obviously, that's not accurate, right? We're trying to measure the electroactivity of the heart. Here we're measuring electroactivity of the skeletal muscles. We don't need that. We need the heart muscles. So, okay. So you can get this slide. I don't know if y'all have seen this from the CDC. It's a little poster form for technical errors in spirometry. If you do CDC, spirometry, technical errors posters. Now you can print off a color of this, or you can order like little poster size. And we have this in our PFT lab at school to train the students and those that come to our spirometry training course. So you can tell there's a lot of errors. So in reality, someone learning to perform spirometry in your clinic, I'm going to say you better know these, have memorized these, and know how to recognize them, or you're not going to be very efficient and productive getting valid, accurate, precise measures if you don't know what these are. You know, if you don't know what you don't know, what do you know? You don't know what the technical errors are. You're going to think, oh, it looks good. Because Like the 12 lead EKG, do you agree that's a passive test? Sir, ma'am, hold still for 10 seconds. They're not going to affect the results of the test as long as they hold still. With the PFT, spirometry, we have to be engaged as the operator. The patient has to be engaged, be able to follow directions. They have to have some cognitive abilities intact. And if they're hard of hearing, I've had to get 1 inch from a patient's ear and yell at them. I normally don't because they were so hard of hearing. Because remember, forced vital capacity is a timed maneuver. As soon as you tell them to blast it out, it starts measuring. If they start exhaling before they blast out, that's going to throw your FEV1 off. You're going to have all kinds of technical errors, and your ratio is going to be off. Okay, so getting an interpretation. So now the ATS recommends using Z-scores for interpretation. So this is not new. I mean, other areas of medicine and other areas of science use Z-scores, just a statistical approach, right, to determine abnormalities. So this does have upper limit of normal ULM. We don't care about that. We're going to use this bell curve in a one-tail approach, meaning only to the lower limit of normal. And when you do the calculation statistically, based on the normal lung function, and in this day and age, I'm going to mention the predicted equation for spirometry. The ATS mentions that you should use, meaning input into your spirometer, is a GLI Quanger 2012. Quanger is the lead author. So that was, they said that in 2012, we should be using that because worldwide, there's about 400 predicted equations for spirometry worldwide. So think about this, spirometry units are sold on the international market. So when you get it, you have to go into the system and go to the predicted equation and see what is it set on. And if y'all have clinics, the same clinics in different parts of the state or across the country, and maybe somebody moves, hopefully they have the same predicted equation that the clinic they just came from, or that could cause some confusion in interpretation, right? Because that's predicting what's normal for that individual. So when we apply all these strategies for interpretation, it could throw it off and make a nightmare. So when you look at a spirometry test, there's only four ways you can interpret it. It's normal, they have obstructive disease, they have restricted impairment, or a mix. They have obstruction and restriction both. So that's I mean, it kind of makes it easier. We only have 4 choices. Which one is it? And then with the newer guidelines, the lung impairment, it used to be divided like into 5 different levels of severity. Now it's 3 based on the Z-scores. So anything, the problem is we know statistically, like if we're using a one-tail approach and we're saying below the lower limit of normal, that yellow and red area, we're going to say that probably 95% of those are normal. There's a 5% chance it could be abnormal. But the hard part for you as providers is getting close to that lower limit of normal. It's kind of a gray area. It's like, I don't want to misclassify them. It's kind of, that's when you got to take more into consideration the whole clinical picture and such. But in general, anything less than negative 1.645, below that in that yellow and red area. So that would be, so Z-scores, when you program it in, it's on your final report, it's only going to show for FVC, FEV1, and the ratio. Now you'll have other indices measured, but it won't have a Z-score because that's all we're going to use for interpretation on there. Then we can see for moderate and severe. So it makes it easier. I mean, if you guys have been around long enough, we used to use percent predicted, right, and the lower limit, you may remember, what was the lower limit of normal for percent predicted? What number did we use? Do you remember for spirometry? Any spirometry parameter. Remember, 80% of predicted was the normal. So that was 78% of predicted. Oh my gosh, your ratio or your FEV1, oh, that's abnormal. So we don't, that can misclassify people. So another reason we're using Z-scores, we don't want to misclassify someone with disease when they're normal, misclassify someone as normal when they have disease. We don't want to do that. There'll be all kind of unnecessary treatment stuff. So here we have this an actual 52-year-old Caucasian male. Predicted equation is a GLI Quander 2012. Here's his actual measured. his FVC, FEV1, his ratio. Here's his lower limit of normal. So you can see that he's above the lower limit of normal for each of those values. And the Z-scores, there's nothing. Of course, his FEV1 in this graphic over here, you can see his FEV1's getting close, but technically it's normal because it's above negative 1.645. So we can look at. Now this particular format, this is from a PFT system, Morgan Scientific, like a body box. Most of like handheld spirometers, you won't get the little graphic over there, but I like that. It makes it easy. So this test was one of my students. She has known asthma. She came to me and said, I'm still having symptoms of my asthma. I said, well, what is your doctor? She sees a PCP, and she had her, I can't remember which combination med, but she's only taking 2 puffs in the morning. I said, 2 puffs? I mean, you should be taking 2 puffs BID. I don't understand. You need to go back and talk. I said, well, do you want me to perform spirometry on you? Do you want to do that? He goes, yeah. So we did. And technically, if we look at it, it's normal, but I noticed the FEF 2575, hers, and it's not really that low, but I thought, you know, for her age, it should be higher than that. So in my mind, I'm thinking, is this a real number? FEF, forced expiratory flow 2575. That means on the expiratory side of the curve, we're looking at the smaller to medium-sized airways when they're exhaling. It's a little bit reduced for me, and I'm correlating that with her symptoms. I said, well, it could be, and your complaining symptom, your inflammation is building up. Go back to your doctor and see what she says. So I just went back and put her on the it was Symbicort, I think because she was on the 80 over 4.5, and she put her on the 160 over 4.5, 2 puffs. I said, well, let's wait a month. We'll do it again. And I don't have her post results up here, but that number went up, her FEF, it was in the high 80s or something. So maybe it represented a real number. So I just use that for example is if ATS says use FVC, FEV1 in the ratio, yes, for determining normal, obstructing, restricting, or mixed patterns, still don't ignore the other things there if we have a good acceptable test. So this is 13-year-old Hispanic female who I got this study from a nurse practitioner friend of mine who works in an allergy clinic in Philadelphia. So the kid came in, we can see her FVC, FEV1 in her ratio. Now this particular system doesn't have the graphic for the Z-score, but you can see all of her Z-scores are in a normal range. There's nothing less. So she has 2.07, that's positive, that's good. FEV1's is there. And then her ratio, negative 1.52, still not less than 1.645. So the first provider she went to said it was normal, it was a PCP. But I circled this other in the FEF 50 and FIF 50. Now this wasn't on the report, I just did a screenshot and I superimposed these, kind of figuring where that would be. So FEF, force expiratory flow 50%. So half the flow rate at halfway at expiration, and FI 50 halfway at inspiration. So just like the volume should be about the same, the flow rate should be about the same when you exhale forcefully and you inhale forcefully. So when you inhale forcefully on this one, you can see that flatten, that loop, and you can tell this was a pre and post because there's a green and red line on there, but it tends to be flattened. So my nurse practitioner friend just kept asking the right questions, and this little girl's like, well, what were you doing the day before? What happened? Well, it turned out it's kind of funny. She was at a Taylor Swift concert in Philadelphia, and she was screaming for hours, and it like strained her vocal cords and made her short of breath. So, but she referred him to an ENT, and they had, vocal cord strain or something that she did. So this is why I think, the inspiratory, and look at the inspiratory loop. Plus, you get more money because there's a different CPT code for flow volume loop versus just expiratory side. And then US providers get more because you're interpreting the loop itself, not just the expiratory side. Okay, this is one RT friend of mine from New Hampshire sent post-COVID patient. Wow, this is really low. So their actual FVC 1.49 liters, FEV1 1.25 liters, and the ratio is 84. If we go over, let's see if I get my pointer, to the predicted ratio is 81. This is 84, so that's increased. Why is that increased? Because I'm thinking that is a restrictive disorder, because as the lung volumes are both proportionally reduced, they're going down, the ratio is increasing. That is an indication they have a restrictive disorder or needs further evaluation. So you can tell it's well below the lower limit of normal for both FVC and FEV1 and for the ratio. And obviously the Z-scores, those are FVC and FEV1 are abnormal. But look at the ratio, 0.48, that's on the positive side. That's normal. Well, it's because this proportional reduction of the two volumes, FVC and FEV1, are going down. The ratio is going up to where it's in a normal range. Because a normal ratio is 75 to 85%, right? So that means of the volume you exhaled in the first second, FEV1, you should get out, an individual, any of us should get out 75 to 85% of the total volume of air we're going to exhale during whatever that, how many seconds that is, we should get out 75 to 85% in 1 second. And that's why this test is so hard for someone with normal, healthy lungs, because they're going to exhale, blow it out, and let go and go, I'm done, I'm empty. It's like, no. It's like, yeah, I am. You only exhale for 1.5 seconds. I don't have any air left. You got to keep telling them, keep going, keep going. We're still measuring. So this is, they're way below the predicted value with 2.6 liters. So this is definitely, this is moderate restriction for that patient. This is another restrictive. So once again, characteristics, volumes proportionally reduced, the volume meaning FVC and FEV1. The increased ratio, normal or near normal flow rates. So that's, so you can tell flow rates, look how tall in that top, this top here, that's the predicted for their peak flow up there. They actually got a little bit over their peak flow. It's a tall, skinny loop, very characteristic of a restrictive pattern. So for you guys, this would be definitely somebody you would send to pulmonary and have them check it. They're going to need a full study, a full body box study, maybe diffusion capacity, maybe they have pulmonary fibrosis or sarcoidosis. There's many restricted disorders that it could be. But even people who are chronic smokers can have airways, because chronic smoking can lead to pulmonary fibrosis and obviously emphysema. So that would be that mixed pattern. Or someone who worked in industry. So they're a chronic smoker, but they work at the Alcoa aluminum plant and they're not wearing the right type of respirator. They're breathing in substances over decades, and now they have pulmonary fibrosis. So that's just one type of example there. So this report I got from another RT, this is way back, this is an older report. It doesn't have Z-scores or anything in it, but this is so unusual to see this fixed airway obstruction. And we can look at on their flow volume loop, here's the predicted, this dot right here is the predicted volume, the forced vital capacity around 4.5 liters. And they reached this, but this is their peak flow up here, and this is where their flow should have been for their inspiratory. So you can see those flatten. This is a fixed area. There's a tumor or something. There's something blocking the airflow. They were able to reach the volume, but not the flow. And you can see those flow rates. So that's the FEF 50%, FIF 50%. They're both severely reduced in their flow rates. You could probably be in practice in the clinic for a long time and never see this. It's pretty unusual. Luckily, I have this old one here. Okay, so reduced inspiratory FIF 50%, reduced FEF 50%, flattened flow volume loop, near normal or normal FVC, and that's what we see in this picture for fixed airway obstruction. Another patient you'd probably want to send to pulmonary, and they're probably, CT scan, maybe a bronch to go in and look to see what they can see. I had, as an aside, one student, not of mine, this was years ago, on the Texas State campus, was rolling down a grassy hill one spring, and then following that event, weeks later, she developed a persistent cough. And like I tell my students, if you're coughing persistent cough is not normal. You need to get checked out. Something's going on. So this student goes to the doctor, primary care. We don't know what's going on. Sends them to pulmonary, and they don't know what's going on. They couldn't see anything on chest X-ray or imaging. So they do a bronch. Go in. Oh, there it is. Get the tool, pull it out. It's those little stickleburr things from a plant sticker. So she's laughing. She inhaled. She aspirated this straight through her airway, right into her lung. And never felt it, because your lungs do not have pain receptors, your lung tissue. So it's sitting there just making her persistently cough, and take it out, and she's fine. So, but that was really unusual. Before and after bronchodilator study. Now, the new guidelines 2019, just to let you know, the ATS now refers to it as bronchodilator responsiveness testing. I don't know, that's a lot. Say it 3 times real fast. Bronchodilator testing. Before and after, pre and post. So the thing with the new since 2019, if your spirometer is older, hopefully all the companies that manufacturers can send you the updated software. They can send you a link. You can download it to your spirometer, so you have the latest guidelines in there for technical errors and everything. But also the new thing for before and after bronchodilator studies is the device, if you have the newest software in there, will calculate, but you have to use the GLI Quandra 2012 predicted equations. The formula is different. So behind the scenes in the spirometer, you need to input, make sure, that's another reason you need to put the GLI 2012 predicted equation in your device. So if you're doing a pre and post, it's going to calculate it correctly. So we're going to, I'm having trouble with my button. But you can see, so the new standard is, well, the old standard was if a person has an increase in greater than 12% for FVC or FEV1 post-bronchodilator and an increase in volume of 200 milliliters. That's the old standard. The new standard is greater than 10%. But you have to use the GLI 2012. So obviously this person had a greater than 12%. 10%. So FVC is 40% change, and the FEV1 was 73% change. That is really high. And this format for this system also put the absolute value for their volume change. That was a major influx. But I wanted to point out that once again, you have to use the GLI 2012 predicted equation for before and after or bronchodilator responsiveness testing for it to do the correct calculation. We can see this is abnormal. All of those Z-scores are below 1.654 or 45. This is the full volume loop for that previous one, just to show you even graphically. Usually it's not that defined, the difference between the pre and post, but I labeled them. You can see in the graphic here, the full volume loop and the volume time curve there, it's very, very obvious that was a very significant response to the bronchodilator. So severe obstruction, here's our lower limit of normal. So we can see that those are below the lower limit of normal. Z-scores, if we look at FEV1, that's going to be severe. There's their flow volume loop. That's a little chair. You can sit in it, lean back. It's flat. Their flow rates is just completely. So this, you can see the predicted is here. All the way up there. Their peak flow should be there. Their peak flow is there. So all that, as we say, that scooped out there, all that is scooped out, that flow, that reduced flow. And so I asked my students, like, airways obstruction, like, well, what's obstructing it? Well, for emphysema asthma, inflammation, bronchospasm, excess mucus, and such, if it's a chronic issue. So very severe with that look for that flow volume loop there. And then the volume time curve, you can see for normal, so this is the volume over time. You can see how laid over that is, and they did not reach a plateau. So a plateau would be their flow rate line would equal that time down here, right? It would equal this. It should be a straight line at some point. But they have so much trapped air and severe emphysema that's why. So before I was doing spirometry way in the 90s and before even 2005, the standard was just let them exhale as much as they can. And I'm exaggerating a little bit, but I'm like, okay, deep breath in, blast it out. Keep going, keep going, keep going. I'll be back. Keep going, keep going, keep going, keep going, keep going, keep going. Okay, now breathe in. I didn't have them exhale for 25 or 6 seconds. Like, well, they still got air. I'm gonna keep them going. And then, have you ever had anybody experience, this is not too uncommon, but that fainting, they'll stimulate their vagus nerve, a forceful cough. And that's why I say you should always be an arm length away. So do y'all have patients sit? Yeah, oh, I was thirsty. I had to go get some water over there. Yeah, that's a good point. Well, they're in a body box. If they fell over, they just hit the side and I'm like, you're okay. And so, no, but if they're in a chair, do y'all have them routinely sit or stand? I would say sit in a clinic. That would be best. But still, because if there's no, you don't want them to fall out and hit their head, then they have a head injury from hitting the floor. I've never had any hit the floor, but you know, I worked in a hospital in Austin. We were so busy, one patient after another. Like, what happened? You're okay. Let's go. Next effort. I got 20 people waiting out there. Let's go. Come on. You can do it. You're okay. But there's no residual of that. They just, it's like a few seconds and they pass out. But that strong cough just stimulates their vagus nerve and make them pass out for a few seconds. So severe airways obstruction. So this is definitely severe because it's less than a negative 4.1 for those Z-scores for FEV1 and their ratio. So that would be more like a fixed airway obstruction, right, from chronic. Okay. Interpretation of technically acceptable PFT results had 3 key aspects. So before you guys, the provider, if you're interpreting, we got to make sure it's acceptable. And I would say that it's best if you can have the formatted report print all the efforts. In other words, you want to see if they did 4 efforts, I want to see the flow volume loops and numeric data for each one. Then so you could apply the standards if it's a good test, because I mean, I hate to say this, but there's some lazy people in the medical field, they want to game the system. If it prints out, they could do 2 efforts, it's going to print out the best one. You don't know, like, there you go. We don't know if that's the max effort, right? The patient has to give a max effort. So I know in pulmonary clinics I worked in, we would print out and you could format, and most spirometers can show all the efforts. You can look at it. So the person conducting the test should be looking between each maneuver. It's not like, okay, deep breath in, blast it out, keep going, keep going, keep going, breathe in real deep. Okay, get ready again. Okay, deep breath in, no, you're gonna study these loops, the flow volume loops, the volume time curves, you look at the data, you're looking for any technical errors before you go to the next loop, because you may need to re-instruct them, like, okay, sir, if it says back extrapolated volume measurement, so what does that mean? It's like, well, they leaked air out before they blasted out. How do you coast them? Okay, deep breath in. Right when I tell you to blast it out, don't hesitate. Blast the air out. We need to make sure it's acceptable. So classification of observed values, it's within outside normal range. That's just determining. So we're taking their measured values, comparing it to the predicted values, and hopefully we got all of their predicted equation is correct, meaning we have their correct age, their height, and their race and ethnicity, and gender or sex at birth. One time I was in a hurry at the hospital. We had a stadiometer wall. I measured this person, this guy, and he was 6'3". I'm walking back to the computer. I'm saying in my mind, 6'3", 6'3", 6'3", 6'3". And in this system, you put in total inches. And what did I put in? 63 inches. And his spirometry came back as FVC was like 180% of predicted. I'm like, Superman has arrived, he's here. I said, wait. I looked, oh, no, I made him 5'3". No, he's 6'3". I put in, he had severely abnormal PFTs. So I'm gonna qualify my statement earlier that don't worry about abnormal spirometry rolls. If they're that abnormal, you need to look at your demographics to make sure you entered their information right. And that happened. I was training some occupational nurses at a semiconductor plant in Austin for their NIOSH certification, and they were showing me some actual spirometry tests they'd done on the workers. Like, look at this, it was abnormally high. I just looked at it, it's like, you got the wrong height in there. and their age was wrong or something, they go, oh, okay. They were gonna, pass them along unnecessarily. Functional classification identified impairment using Z-scores. Is it normal? Or for impairment, they have obstruction, restriction, or a mixed pattern, both. So both would mean their vital capacity is reduced and their ratio is reduced. By the numbers, that's a mixed pattern. So they have a decreased volume and the ratio is reduced. So the ratio we look at for indications of airways obstruction, right? That's the main indicator. Integration of clinical data to inform diagnosis and guide therapy. So obviously with spirometry, we can't diagnose based on a spirometry test, right? Just like any other lab value, you're gonna put it together the clinical picture, the patient's history and all that, and hopefully they can give you a good history and you can come up and make a diagnosis and guide therapy. And I think I'm done. Any questions? I can travel.
It might be via Zoom because we're in different states, but.
I can do Zoom. Oh, just.
First of all, thank you for your talk. Completely normal spirometry is super athlete. How do you pursue, like, yeah, they're normal, might be 120, and I get 85 and 85. Are there scenarios that you could still do a
You mean, but they have symptoms? They have symptoms, you're saying? So that's a good question, because you guys probably agree, you can have perfectly normal spirometry, but still have asthma. I'm using that as an example, right? That doesn't mean they don't have asthma. Because remember, for our lung function, it's a very wide range from normal to abnormal. Not like lab values, like sodium, right? Very, very narrow range. Or in an arterial blood gas, like the pH of our blood, very narrow range. Lung function, big range for normal. Why? Because you can have somebody of the same height, but their thoracic cage is wider. This, like Dr. Weingarten says, this person has large lungs. They have large lungs. Like when I was in the 80s, when I was doing triathlons, and this was the time when Lance Armstrong was doing, I don't know if you know, he did triathlons. I'm a little bit older than he. I got to know who he was, but I think he'd always beat me. But I think for his size, he probably has, if I did lung volume, he probably has larger lungs than anybody his size. But for the athlete, so if they were having symptoms, the next step would be maybe bronchoprovocation challenge testing. You could do that. But if they're not, they can be super normal as an athlete, especially younger, to have better elastic recoil, so they can generate a lot of force and get a lot of their air out. Does that make sense? Yeah, because if you see, that's a good point. I've seen people, and so even though if you're using percent predicted, yeah, even though they're over 100% of predicted, well, that's not really good, because using percent predicted, it's 80 to 120% of predicted. Or even if they're 95% of predicted on their FVC and their FEV1, if you did a pre and post, their best might be 118% of predicted. You don't know. But I'm just thinking, if you have a high suspicion, maybe there's asthma or something else going on, like you said, why not do a pre and post bronchodilator? Just to see, to help you rule it out. And then methacholine challenge or other bronchoprovocation may even further rule out asthma too. But that's a good question. Any other questions?
Thank you very much. So we have one more lecture on the schedule, but in the interest of time, what we're going to do, that's from Dr. Storms, and it's about chronic cough management. We're going to post that on our website to give you the opportunity to go and look at that whenever you want to. We've got all of Dr. Storm's associates back here on the second row. If you have any questions in the meantime about chronic cough, feel free to talk to them and they'll know all those answers. We're going to break for lunch. Be back here by 1:30 to start. We have one more lecture that Dr. Weibel's going to do. Yeah. So we want to do that. And then after Dr. When you come back, you talk as quick as you want to. After his talk, we'll do our drawing for the gift cards. And just really appreciate it. Also, we're going to have, I think all of these presentations will be on the website as well. That's the plan. So you can go back and refer to these. There's a lot of good slides there that I know some of you try to take pictures of, which makes it hard sometimes because you'll have that information. Any other announcements we need to make before we break?
Thank you for staying here till the bitter end. So the topic I was given is what do I do with this baby? Well, don't throw him out with the bathwater to start. So stand up here to get away from the feedback. All right, so okay. No, this was a thing with a previous provider. There we go. All right, I have no relevant disclosures. So again, some objectives, want to gain some knowledge about some various clinical presentations. A lot of these walked in the clinic and was in front of me over the years, so hopefully, maybe you'll see this as well. Understand when to test and not test, and then also maybe some short and long-term counseling for unique scenarios. So you have these different age groups, right? Just try to cherry pick a few. So perhaps, the baby's born and the pediatrician's worried, like the little umbilical stump ain't falling off, getting kind of concerned, and, they read in their textbooks this could be an immunodeficiency. So what do we know about umbilical stumps? Well, there is perhaps a delay in when that stump falls off. A lot of that has to do with how the parents are caring for the umbilical stump. But you can see that on average, maybe it's around day 7, but is when the baby came in, but otherwise the baby looks healthy. There's no family history of immunodeficiency like Dr. Crisp was talking about earlier. And the baby's fussy because you're trying to examine them, but otherwise looks good. So again, what is delayed? So you can see there is a range for where the stump can fall off. It's probably completely normal, especially in an otherwise healthy baby. But if you are worried about an immunodeficiency, the one that probably comes up is this leukocyte adhesion defect, where neutrophils are stuck in the blood vessels. They can't get into the tissues to kind of help with this process. And you could do flow cytometry for CD18, but just get a blood count. Because if all the neutrophils are stuck in the blood, you're going to have 50, 100,000 white blood cell count. So that's an easy screening test. We've talked about some easy and second level tests. Do just a blood count. If it's normal, you should be very reassured. All right, so again, I did my lecture before I heard these other lectures, so some of this is reinforcement, but you now get presented with this term baby who is born without complications, and they're worried about a cow's milk allergy, right? Everyone uses the word allergy. You have to separate that out like Dr. Sommerhalder kind of went through earlier today because they're noticing some blood in the stool. I think Dr. Silver's already kind of discussed this, but hey, let's evaluate and treat. So realize there are other non-allergic conditions. Even though it's called allergy, it's not IgE mediated. So when I say the word allergy, in my mind, I'm thinking IgE mediated. So it's a food reaction, just slightly different. And as was discussed earlier, it's usually cow's milk. It can be other foods. But typically you eliminate the food, a few days, it goes away. Prognosis is excellent. It usually resolves within a year. And then, around a year, you're going to have a discussion. Should we start with some baked milk and then kind of move on from there? And I found this publication from last year had this nice algorithm, but basically if you dig into that algorithm, it's either is the baby breastfed or bottle fed. And if they're bottle fed, you're going to move to these, extensively hydrolyzed formulas. You might go amino acid. If they're still breastfed, well, think about the foods that the mom is eating and have mom take it out of their diet, and usually that resolves the trick. If it doesn't, you may end up with gastroenterology as part of the evaluation. I think this is interesting because it comes up a lot. I think it was discussed with Dr. Summerhalder, but like you see the one child, the mom's like, I got a sibling, I got a baby on the way. I've been avoiding it because of one child. What about my other child? And so I thought this was a really good article that looked at this. And so overall, that reported risk is around 7 to 8%. Back in the day, I don't know, a decade or two ago, I was doing something like, yeah, just give it to the kid and see what happens, but it's not zero risk. So the study, they took 154 children, they did skin testing, and then the parents introduced the food, and there were some reactions, 5%. But what you also see, and I think this was what Dr. Summerhalder had mentioned, was when do you do the introduction? Because if you're keeping it out of their diet for years and years, we know that's increasing the risk for reaction. So you definitely saw more reactions occur when you waited longer and longer to approach that situation. But the good news is you do a skin test, and if it's negative, basically you're at 100%, it's not your problem. So then the question was, A, we skin test, it's negative, should we just tell the parent do it at home or do it in the clinic? And what they found is you're gonna get good results with both, but when you ask the parents how they feel comfort-wise, they were totally happy to hang out in the clinic and do it. So you just need to have that discussion with the family, like what locale do you feel comfortable having this, even though it's a low-risk challenge. Easier to do a few in the clinic until you feel comfortable with advising them to perhaps do it at home. So the other thing you should know, at least so far, and this is some of the LEAP study and other data that's out there for introduction of peanut butter, is at least the first time they're exposing it to a kid at home, no one's ever died. So I think that's helpful as we're trying to tell parents, like, introduce these foods. Now you could argue, are they getting exposed in other scenarios, but the actual ingestion hasn't been reported. And again, I mentioned the later you wait, the more risk becomes. And so, you know, in that LEAP study, with that group of patients who had egg allergy or severe eczema, and they had the positive test or the IgE, very few actually had reacted to food challenge. So again, if you're going down that scenario and that algorithm, the NIAID, still think about potentially doing a food challenge, because that positive test can easily be a sensitization, not representing a true allergy, and we get overdiagnosis and delays in introduction. All right, so this is very common. I kind of love the baked egg, baked milk scenario. So again, this is very common that you'll come across. So for example, you have this 1-year-old female, and the PCP said, hey, I'm worried she has this allergy, please evaluate. So as you hear the story, the parents kind of say, well, you know, we introduced some egg and she had a little rash around her mouth, happened pretty quickly, stayed away from a bit, and then we tried it one more time, and you know, now I'm getting more hives all over, and she threw up, and they had to go to urgent care. And since that second reaction, they've kind of been completely avoiding it, including all baked egg. They don't want to have anything to do with it. So what do we do for that? And just a little more data. So I mentioned it is the most common food allergy in children. Usually milk is going to be in the first year of life, but overall egg is the most common. And I just made up some testing here, but this would be probably pretty common. You do your prick test where your wheal and flare is significant at 11, your negative control is 0, egg white also significant, and then you got some blood testing that shows the more heat labile protein of the ovalbumin and the more heat stable ovomucoid. So you got some numbers there. And so will they outgrow it? It kind of depends, but some factors to think about is what is their original history. The more severe the reaction history, the less likely they're going to outgrow it. The higher the IgE, less likely. So some of those can factor in, but you still want to know about baked egg because that's in a ton of stuff, and their birthday's coming up and they want to have a party. So this is Hugh Sampson and others. This is out there, and again, all these slides you should have access. If you don't, I have my email, I can give it to you later. I don't have it as a slide, but think Dr. Silvers and just put my name instead of Silvers, dr.weibel@aspireallergy.com. I'll send you whatever slides you want. So it's interesting because this, they kind of grouped it in terms of the blood tests. The cutoffs are like 50 on an egg. It's really high, but of course it's above it. We're just going to stay away from it all. There's too much high risk in this protocol. But as you get to lower numbers, and this was brought up earlier, it depends on how old the child is, whether they're under or over 2 years. they talk about, hey, let's consider a baked egg challenge. This is what I like to show my families. I make copies of this, I give it to all of them, and the milk just looks like the egg, because if you can tolerate the baked egg, your chances, so the y-axis is becoming tolerant, it's not your problem, and this is time on the x-axis. If you can tolerate the baked egg, you are at a high chance over the years, you're actually gonna outgrow that egg allergy. We can talk about OIT, we can talk about OIT, speeds this along as well, even despite baked egg. But I like to know that because that's how I'm gonna do some anticipatory guidance to the families versus they fail the baked egg challenge, that egg allergy ain't going anywhere soon, and I'm really kind of starting to talk about other options, whether it's omalizumab or certainly OIT. How about this? You'll see this from time to time. So a little older, now we're in the toddler ranges, so 2 years old, gets these kind of bumps that are happening. It's usually in like skin exposed areas, but it's not an urticarial wheal. It's not coming and going. It's kind of hanging around for hours, maybe days, and they've treated them with topical antibiotics and maybe some steroids, and just kind of getting upsetting to everybody. Anybody got an idea? So papular urticaria, it's another variation of urticaria. It's more from insect bites. You can see some common causes. It can last for a while, so it's not coming and going. And the problem is how this works is these new, I think it's like an id reaction, your immune system just gets all stimulated. So even new bites in another area can stimulate old bites to pop up. And so it can be a little confusing sounding, but I've seen a number of those cases over the years, so papular urticaria. Another scenario which will come up is you see the young child, the toddler, they're having some coughing, they're having some wheezing, you're thinking like, could this be asthma? But right, you can't really do that nice spirometry we just learned about. You don't have oscillometry, which now I guess is gonna look for airway resistance. How you get them to do, ENO if you have that in your office. So there's a lot of studies, mainly out of, I'm blanking on his name, but he's in Arizona now. Thank you. Yeah, so he's behind all of this, but it's called a modified predictive index. So I've often used this when I talk to parents and they're having some asthma-like stuff and they really want to know, is this going to keep going on and on? I mean, you're going to follow them, but like other disease processes, you have different criteria, major criteria, minor criteria, and you can read through them as well as I can. But at the end of the day, if you meet the criteria and have a positive index, you're at high risk for developing asthma that persists past the age of 6, versus if you have a negative index, by 6, it's probably should be all gone. So, right, you have these early wheezers, late wheezers, persistent wheezers. So if you're trying to figure out, right, do I have a persistent wheezer in front of me, maybe this can help you in your assessment. All right, so not this child, this was from the internet, but it looked like this. This mom, and I can still picture them in New Braunfels when I was working, the mom brings her in, she's like, my pediatrician sent me here because my 1-year-old has a food allergy, because every time he eats, he gets all flushed and red in the face, and you kind of ask a little more story, and what food is it? And they're like, it's like every time he eats. I'm like, well, that's kind of odd. Like, I don't think your kid's allergic to every food. And a little more story, like it didn't really bother him. The rest of his body was fine. It was just like on the face, it get all red. And so, what do y'all think? So auriculotemporal syndrome, Fry's syndrome. Again, I reference. I don't want to go forward and I can't go back. But basically, in the old days, there used to be this history of a traumatic delivery, forceps. You'd kind of damage the parotid gland, the nerves there, and so you get stimulation when you would eat. But actually, a recent study showed that at least half or more of these kids, there's no history like that. So if you get the history, great. If you don't have the history, it doesn't rule it out. Sometimes it can happen with sweating or overheating, but again, it's usually on one side, could be both sides. We're not going to test. This is not an IgE-mediated reaction, and hopefully within a few months or years, it's going to go away. And the mom was very happy. She was like, yeah, I didn't think it was an allergy, but my pediatrician sent me anyway. You'll get those cases where mom's like, or the patient's like, why am I even here? So you can help unravel that for them. All right, so this one actually I saw them about 2 weeks ago. It took me 2 visits, but it was a 2-year-old female. Kind of came in with atopic dermatitis as the diagnosis, but had this recurring facial erythema. And so we saw, I think in an earlier slide, when you're a baby, eczema is more on the extensor surfaces. As you get older, it goes into flexural surface, but infants, toddlers, it's often right on the cheeks. And this is where her rash was. It wasn't unilateral. It wasn't with eating. It would just be there. And the mom said, yeah, moisturizers kind of work. I'm like, well, yeah, moisturizer does work for eczema. And we were talking about, well, we don't want to put steroids on the face with other creams. So she just wanted to know like why it was happening. But it'd go away really fast, right? So if you think atopic dermatitis, it really shouldn't go away fast. So it was blushing. I'm like, blushing, right? And like we blush, right? But it's actually a thing. So in younger kids, and what happened on the second visit, the kid was kind of okay looking. I'm like, wow, you're doing really good. Your moisturizer is working. I don't need to talk calcineurin inhibitors or topical corticosteroids. And then I start to approach her to do a little examination, and she's kind of getting upset on me. And then like, here come the cheeks. Like she's not even crying, but just that emotional stimulation caused that. I like back off for a bit, and like within 5 minutes, it like went away. I'm like, wait, what's going on here? So I'm like, Google. I'm like, blushing, yeah. So anyway, but that's what was happening. The kid would get stirred up, and whether it was heat or strong emotion, it would perfectly on the cheeks. So perfect places for eczema in a child, but it would just come and go so fast. And yes, you need to think eczema, you need to think about slack cheek kind of stuff, but blushing is pretty common. Hopefully I'm not blushing as I do this presentation. We talked about some penicillin, had a great talk about how we approach this. And as we know, when you're labeled with allergy, it leads to all downstream issues, whether you're more likely to be hospitalized or need higher level care or have other issues, especially including other antibiotics. So there's this large study that looked at kind of these outcomes in many children, but I think our role as allergy providers is to find these patients and to figure out, can we evaluate them, can we delabel them? So I found that, I thought it was a great reference, but it was like an abstract, so I didn't find it in publication. But what I thought was interesting is they went straight to oral challenge. They weren't skin testing anyone, and they had a whole lot of kids that they reported, but they had these odd categories, and I couldn't even find what the low risk they were reporting, but no risk they classified as just, you had some highs back a year or so ago. So we know what we do with adults, right? We'll say, we'll wait 10 years and then we'll maybe approach you. But there's a lot more data now that even within the first 6 or 12 months after an infant or toddler is having a reaction, like maybe we should approach that scenario and figure out if we can delabel them appropriately. So I thought it was interesting because they even included people high risk, like you had positive testing, you had anaphylaxis, and at least this is their data, which hopefully it comes in publication, but you can see we're in the 90% range of success for all these categories. So again, we have testing. I personally would not go direct oral challenge if I heard anaphylaxis. I'm gonna do some skin testing, have some shared medical decision-making. But again, I think this will continue to evolve, but definitely the low-risk groups or the no-risk groups, like it's just highs, we're seeing that 96, 97 or more success. So I don't know if you're doing direct oral challenges in the clinic, but it's very rewarding. It's very straightforward. It's minimal effort for your MAs. Although this week I did have a direct oral challenge, actually on Thursday. I knew it was going to go wrong because you probably think about who the patient was, but 26-year-old, lots of other psychosocial issues. I react to all kinds of medicines. I'm like, mom was in there with her. Mom's like, yeah, when she was 1, day 2 of amoxicillin, she had a little rash. That was it. Avoided it since. I'm like, sure. But in the back of my mind, I'm thinking, something's going to happen here. And something did happen. So we did a 1/10 of a dose challenge. So like 50 milligrams of amoxicillin. About 15 minutes later, she's like, my arms are itchy. I'm like, okay. I don't see anything. Exam is completely reassuring. I'm like, what do you want to do here? Because I'm thinking, if I do more, something's going to happen, but I'm here for you. So I'm like, well, let's not do the full dose, the 1/10 of full. We'll do 5 milliliters, so a 250 milligram dose. We didn't. Now she's like, my arms are itching more, and now I have a headache. I'm like, well, I guess your mind has a strong connection to your body. You're having something, but I can't classify it as an allergic reaction. So it was a little frustrating. Of course, it was like the first directorial challenge with one of the MAs there at New Braunfels. I'm like, I'm sorry this was this scenario, but some of these patients will have symptoms, but to objectify it, she didn't have any hives, she didn't have any swelling, she didn't even cough or clear her throat. And that was her original story. So I think when we do these challenges, you have to figure out like, well, what was the story? Because if it doesn't happen again, and you have a subjective complaint, it's probably not a reaction, but it's not going to probably help the next provider who's going to see this patient. So I just, on the way out, I'm like, yeah, you should probably just stay away from the medicine for now. So. All right. Have all of you seen KP, keratosis pilaris? Very common, sometimes misidentified as atopic dermatitis, but it's right, your little hair follicles get plugged and you get a little keratin there. It's all chicken skin. It's usually the arms, but it can be the face, can be other extensor surfaces. You know, a lot of people are affected by it. It peaks in adolescence. Usually doesn't bother people except, psychologically, but who wants to have this, lumpy, bumpy skin? And there is thought now there's no more connection like increased incidence with patients with atopic dermatitis. There's all kinds of treatment. You can do watchful waiting. You want to avoid things that might stimulate more of the underlying KP to be exacerbated. We'll use moisturizers, soaps, exfoliants. I typically do the lac hydrin. I get this from my derm colleagues. I guess they have lasers that they can use as well. But usually if I can't figure it out with some moisturizer or Elidil or mild topical lac hydrin type solution, I'll usually send them off to derm and see what they have to offer. But again, you can decide where you want to draw the line in treating it. All right, FPIES. Dr. Silvers already stole one of my slides. That's okay, but I got a better slide than he has. So, all right. So again, I think we went over this morning. Most do get better. We talked about the time course. I've only been burned twice in 22 years. This is where I've been burned. Once at BAMC and once earlier this year. I'll tell you real quick, 5-year-old, dad's like, it's soy. I'm like, okay, what's the story? Hives, vomiting. I'm like, okay, what's the story? Because I knew there was something weird about it, and the dad, and you'll read my note if you ever read my note, I'm like, there's something off here, but you keep saying the kid had urticaria. I'm like, that's not FPIES. So let's do some skin testing. It was negative, of course, so you're feeling really good about this. We did the challenge in the clinic, Alamo Heights, went great, high five. Kid's doing great, kid leaves. Hour later, the phone rings like, we're like at home and he's starting to vomit. I'm like, so like, come on back to the clinic. Looked really great, wasn't hypotensive, but I'm like, I can't start an IV. So that's the one and only time I've actually had to call 911 since being in private practice. The time before was at BAMC, same kind of scenario where it's just like, something's not right, but they left and then they came back and the kid was vomiting. That kid was more lethargic and got admitted overnight. But again, FPIES is out there. You can be burned by all kinds of things but if you've had to be burned by something, this is, I think, what's going to get you, because there's going to be something that the parents say, like he kept saying urticaria. I'm like, really? Okay, you're saying it. I'm believing you. But it's a little delayed vomiting, so some of the symptoms can overlap. It wasn't like 4 hours later that the kid was vomiting in the history. They should resolve. His did not. He was 5 with soy allergy. And they can have other underlying atopic disorders like Dr. Silvers was saying, or the one that I think did burn me was an atypical FPIES and very low skin tests, but it wasn't negative. So different kind of, this graph I think was nice because it says, when do you have symptoms and when is it getting diagnosed? So I know it's tiny print. I can't even read it from here. But as was discussed earlier today, there are a lot more foods that are being recognized. So it's not just milk and soy and sweet potato and rice and oat. I saw a kid a few months ago and it was the classic story for peanut. I'm like, wow, okay, well, you got the perfect story for FPIES. So you can see all kinds of foods, and the more atypical the food, like peanut or shellfish, it's been taking people longer to figure it out. So always keep FPIES in the back of your mind, no matter what the food is and what's the story. This is a slide that Dr. Silver showed in terms of kind of the resolution in months. So you can see it can take a while, but I mean, here we are at 5. Like most things should be gone, but there's some outliers. I guess I had one of them. Thank you, family. It ended up fine. So this is my last slide, right? So who wants to be an allergist? So those who are in the audience, I have found Ask the Expert on the Quad A site is really nice because you go to this link, you type in your search words, and you get some really nice cases there, and you see the expert in the field responding. So I've always found that a good resource. Of course, you can phone a friend, you got other people within the group, but you only have 30 seconds to give us the case, so make it concise. Hope whoever you're talking to knows what they're talking about. And I guess if I can give you 4 diagnoses and you can go 50-50 on me, but then you got to pick one of the other 2 remaining. So with that said, that's my last slide. So thank you for your attention. And there's some more money up here, I guess, right? Yeah.
Okay, guys, thanks for sticking it out to the bitter end. I may have to draw a few of these because there's a lot in here and not a lot of people in here. So, Corey Schulte, are you still present? She had to get a flight. Okay, we're going to allow the flight thing. Is her flight in her car or in an airplane? Awesome. Okay, let's see. And if you know somebody who actually had to catch a flight, we will make an exception for that. Okay. Next one, Alvin Aubrey, Dr. Aubrey. Woo! Can somebody bring that to Dr. Aubrey? Donnie's going to bring it to you, Dr. Aubrey. Okay, we got 2 left. Who's it going to be? Crystal Salazar. Woohoo! Come get your gift card. I'm doing pretty good drawing the people that are here. Okay, I shouldn't have said that because now like the next 6 are going to be people who are not here. Chelsea Word. She's on a flight. Do we have any way to get to her? Shh. Y'all tell Chelsea that I tried to give it to her and Overstreet said no. Do we all know that? Okay. Sophia Gawley. She's another one, right? And nobody's got a way to get to them. Is this terrible? We're changing the rules. Okay. Jofi left and she's on our board. Everybody tell her she lost. Did she know she had to leave? Heather Hunstable, not in here. See, we jinxed ourselves. Jennifer Vandegrift. Woohoo! Okay, guys, thank you so much for coming. You guys were wonderful this weekend, and we'll be in touch. Remember, you can watch the Chronic Cough Talk. Scan the little event information that's about to pop up, the QR code, and then you just click the Chronic Cough button. The talk will come up. And we'll send out a survey to you guys as well after this, so be watching your email for a survey here in the next week or 2, okay? Yes, we'll send an email about that as well. Yes, so CMEs, there's a slide that talks about that as well. Can you make sure that this progresses, or I guess I don't know if I can you progress it 1 to the QR code? Perfect. Okay, thank you guys so much. Bye.